Okay, so we're gonna record. Hell yeah, I did. Did I bring a pot of coffee? It's 3 hours of lecture. I need caffeine, people, and these kids in SIC wore me out yesterday. I didn't stop running. It was a great day, though. Okay, let's just back up. And I think we're recording, so I think we're good. Let's back up and let's review, because that's the way my brain works. So how many types of acute kidney injury do we have? Talk to me about it. Pre-renal. Okay, so that means before the kidney. Give me some instances with pre-renal. All right, your patient yesterday.
Like if there's like a blockage in like the ureter.
So bilaterally, it's got to be not ureter, but the renal artery stenosis, so blood flows to the kidneys bilaterally. Your patient? Dehydration, right? She had a patient that was at home that was dehydrated, right? We don't have enough volume circulating. What else? Hypotension, and if it's prolonged, it's going to extend into intrarenal, right?
Bladder stones.
Bladder step in the bladder? Post. That's post. Pre. Think before the kidney. What about heart failure? What about sepsis? Anything that alters that perfusion of blood is going to be the cause, right? How do we fix that? I guess when you answer a question like that, that's true. So we've got to fix the problem. So your brain says if it's caused by heart failure, we need to give meds for heart failure, right? That makes sense. If your brain says that we're dehydrated, we need to give fluid. Okay. So think about what's going on with the patient, not just, oh, this is kidney failure. Why is it kidney failure? Okay. Tell me about intra or intrinsic. Same language. Okay, so if I had that extended, I cardiac arrested for an hour and they're teaming me, I have that prolonged ischemia. Right. What else? Rhabdo. What else? What kind of toxic? Oh, good one. So contrast dye, right? Contrast dye could be it, or aminoglycoside, or maybe I overdosed on insects, right? Okay. What do we do for intrarenal? We didn't talk about it yet, did we? Because it's coming up. So we'll talk about what phase they're in. Not only do we have types of kidney injury, we have phases. Now you think, oh, come on, Lori, now you're complicating this even more. But we've got to know what phase they're in because we treat them differently. So as we progress, we're going to talk about those phases and how you can recognize your patient is in a particular phase. Okay. Acute tubular necrosis or intrinsic, definitely harder to treat. Definitely an increased chance of having permanent kidney injury damage versus pre-renal. Okay. Post-renal is a simple fix, right? I got bilateral stones obstructing. I got a huge tumor in my bladder. I have a large prostate. We go to surgery, right? Alleviate, like my father-in-law, like I said, you alleviate that obstruction. Things are good. How do I know there's an obstruction? I just guess. Say it again. CAT scan or an ultrasound of the kidney because we're looking at that kidney to see if that kidney has stones in it, tumors in it, those kind of things. Or KUB, kidney, ureter, and bladder. We could take a look and see if there's a big tumor there, right? Okay, good. All right, let's finish the intervention overall for acute kidney injury. Then we're going to go specifically with the phases. We didn't talk about them, right? Diuretic. Okay, good. I didn't think we would. Okay, so nutritionally, let me just preface it. I will ask you a nutrition question. I will ask you a nutrition question. Now, will I ask you to tell me if it's 1.2 or 1.5? No, because that's why we have dietitians who are experts in this, right? But I know I have to limit protein in those renal patients, okay? But I also know that I got to restrict protein or potassium, sodium, and phosphorus because why? Right. So I keep retaining it. So I'm going to have to do, and I always say the renal diet is like, I think the coolest because all you can really eat is air. Seriously, when you get down to it, you're like, nope, that has phosphorus. Nope, that has, And I don't remember, did I put like sources of phosphorus and, did I? Excellent, okay, good. Because those I would recommend looking at, and we'll talk about it as we go along. More so with the chronic renal failure patient than the acute. The acute, what in the world? The acute patient may be on some tube feeding, and we may not do such a fancy diet alteration, but in a chronic case, we will. Okay, I told you, because I don't have, oh, I didn't have, why am I anemic in renal failure? Karen? Yes, right? So if my kidneys aren't functioning and I can't make that erythropoietin, I'm going to be anemic, right? So, and could I be anemic falsely with dilution? If I'm in fluid volume overload, right? They come in, they're really dehydrated, their hemoglobin's 14, I give them IV fluids and they drop down to 8. They didn't lose 8 grams of hemoglobin. Do you guys get that? So you really need to know the fluid volume status of the patient. Now, am I going to sleep over a hemoglobin of 10 in a renal failure patient? No, you guys. I know it's not normal. They're not used to higher hemoglobins than hematocrits. So a couple things: minimize blood draws, and we used to ask for orders to give to draw in pediatric tubes, because I mean sometimes I've drawn as frequently as every half hour. So I'm making them anemic, right? Very common. There's all kinds of literature out there that talks about how we make people anemic in the ICU from so many blood draws. So really try to do them all at once, because you know you have to waste if you have a line. Try to do them all at once and try to minimize. Okay. Stress ulcer prophylaxis. I gave a bunch of that yesterday. What did I do? Protonics. What else? Say it again. Carafate is not a common one in the bundle. We did give Carafate. Jake and I did give Carafate. Carafate, if there already has ulcer, it'll sort of make this paste and sort of protect that ulcer. Pepsi. Yep. Yep. Okay. And then we actively look for bleeding. Because remember I said the platelets could be a little off, and they could be bleeding, right? So actively look for bleeding. Like you're going to check the stool. You're going to check your aspirin. You're going to look at that emesis. Now, it'd be interesting. Heather's patient threw up a lot yesterday before she came. I wonder if they tested it. I imagine it was probably positive. He had varices and bleeding. And
Yeah, they never said it, if they had tested it or not. They could take him down for another CT
well, he had necrotic.
so it showed some rolling off the fluid inside.
Yeah.
I thought it was going to be
And that's, he's way sicker than Jake's patient, who's the resident, the sickest patient I've ever seen. And I look at this guy, not on the vent, but really, really sick. Necrotizing pancreatitis, bad news. Okay. So I would probably assume he's bleeding, you know, make that assumption. I think he was on Protonix BID, wasn't he? Yes. Yeah. Now, and I think Kara talked about this. She talked about the EPO. And because I can't produce it, I'm going to give it, right? So you probably have seen Retacrit. That's the big name that everybody's using now, that Retacrit. I'm going to give you generic and brand names because that's just what we do here. But on boards, it's going to be the EPO alpha. It's going to be the generic. So, or Aranesp. Now here's me, you know, because I'm a little bit bougie, I guess, but it's a once a week shot. If I was a patient, I'd like to get Aranesp once a week, right? Instead of EPO, which is 3 times a week. So I'm like, poke me once instead of 3 times, but I've seen them sort of transition back to the Retacrit. And I don't know if it's a cost thing, an insurance thing, but depending on where you go, but they both have codeine in it. You guys see that? So you shouldn't not know what that is. And I'll get into chronic renal failure, what we really should look at when we give these meds. So just know that that's a med that we can give in acute. Explain diet and fluid restrictions. And one of the biggest things that I write on orders with the renal is 1 liter fluid restriction, sodium restriction. So really having that conversation, they don't know what a glass of 8 ounces is. You got to show them. So really explaining, and depending on what phase they're in acute kidney injury is whether we restrict or give. Everybody with me? We didn't get to that yet. So depending on what phase we're in, they should definitely keep an eye on their blood pressure. Honestly, I don't know if I was counting my own resters, I'd probably speed up or slow down. So that's probably not realistic. But the blood pressure and the pulse, very important because it can tell me fluid status, couldn't it? If I started getting really dehydrated, would my heart rate go up? Yeah. Or if I'm fluid excess, wouldn't my blood pressure go up? Because I'm not peeing. So really paying attention to those vital signs is crucial. Again, staying away from people getting the flu shot, COVID now, add that to the list. Keeping people away from large crowds so that they don't get infected because they're at increased risk. Remember we talked about that? And then the last, describe medication adverse effects. I'm going to spend more time in the chronic renal about the meds because that's where you're going to see more of it. Acute, we're treating it right now. We might start dialysis. We might restrict some things, but I'll spend more time about the medications in the chronic, okay? So this is where I'm talking about. And more often than not, it's the intrinsic or intrarenal that we go through these phases. Because pre is, we fix it or we transition into intra, right? Does that make sense? Pre is, oh, I drop my blood pressure, I give back a volume, and they're better, right? I fix the pre. Intra is where we have a little bit more complication, things don't turn around as quickly. So the initiation, and I'll use Jake's patient yesterday. I was very concerned about his patient. He was getting fentanyl, he was getting Ativan, and I said, you gotta watch this pressure. He was only about 118, I think, when we started, right, Jake? And as later in the day, it was like 80 over something. It was in the 70s last night. So very important when you're giving drugs that could alter that blood pressure. And I said something, I just have this feeling he's not going to tolerate these medications. So then I was like, oh, that is the onset. When I drop my pressure, when I cardiac arrest, you guys see that? That's the onset. When I have lacked perfusion, when I introduced that vancomycin and damaged my kidneys. So the onset is that initial phase. And this can last, and no one, and I am not going to ask you, please tell me how long this phase lasts. That's a stupid question. That's a knowledge question. You just need to know what phase they're in so you know how to treat them. Make sense? Okay. So it lasts about hours to several days. And that's why I said, Jake, I bet when we come back today, his BUN and creatinine are going to be elevated. BUN did go up. Creatinine did not yet. So he hasn't transitioned into acute kidney injury yet, but he will. Well, they're extubated. They're terminally extubated. This phase, and a lot of times we don't even know the initiation unless we know, hey, they were out at Friendly's getting a sundae and they cardiac arrested at 2 p.m. That's when we know the injury occurred, right? A lot of times we don't know. We give a narcotic at midnight and we don't go back in to see the patient for 4 or 6 hours. They could have been hypotensive all night. So sometimes we don't know the initiation. Okay. Or we could chase it back to a medication that's nephrotoxic, or the CAT scan dye that you guys were talking about earlier. So a lot of times we don't know, but when we see the patient do one of two things. So it switches when we become oliguric, so that's 400 or less a day, or anuric. And that's one of the first things that I'll notice is a drop in the urinary output. And didn't his fresh blood or urinary output drop? So once his pressure dropped, his urine output dropped. It all sort of came together. Does that make sense? So we look at, and he's now positive 21 liters. So he's even 2 liters more positive. He's positive 21,000 milliliters. How much is that in weight? Don't answer. 21 kilos, right? Because, did I say 21? Yeah. 21 liters equals 21 kilos. So do your math. 21 times 2.2 is how many pounds did this man gain? How much? Ish. Just in fluid. But where's the fluid? So he looks intravascularly depleted and they wanted to start a diuretic. Is that a good thing? Because what it will do? Make him even more hypotensive. Do you guys see the connection here? You guys got to be thinking. You know, I said, oh, I don't know about this Lasix. I don't know about this Lasix because the fluid's out here. Lasix won't get that fluid. What do I need? Don't answer. Nope. Albumin. Albumin. And what was his albumin level? 1.6. Because I kept saying, no, why don't they have albumin? Why aren't we giving albumin? Because if I give albumin, I can pull that fluid back into the space and then I could chase it out, right? Then I could get rid of that excess fluid. But if it's out here, you can give as much diuretic as you want. It's not going to fix it, you guys. You're just going to make them more hypotensive. Use your brain, okay? All right, remember what azotemia is. That's an elevation in BUN and creatinine. So when azotemia does an absence of, so here's the thing. And I want you to be cautious of this. One of the most common things we see is a drop in the urinary output because the body says, stuff's going wrong, I'm gonna reserve. But there can be a normal output failure as well. There can be a normal output failure as well. The way that I know they're in failure is their blood work. I can have a crappy UN and creatinine, but they're making urine. Everybody got that? So that's called a normal output failure. More often than not, you'll see them drop their output. But some don't get surprised if they're still making urine. So pay attention to the BUN and creatinine. So reversal at this time is key. So if I'm in surgery and I drop my pressure, you treat it. What did you do yesterday, Heather, with your patient? First thing in the morning.
We ran up an LR.
They gave him fluid because he threw up all night. They gave him fluid. Okay. First thing, and I'm like, because he wasn't throwing up when we got there, and I'm like, what's going on? Oh, they're giving back the fluid that he threw up last night. So they're using a preventative way. His pressure was fine.
Yeah.
But they were being preventative. They're being preventative in their measures so we don't get to that point. Does that make sense? We have to be, as nurses, very proactive. You always have to be looking for things and going, well, that doesn't seem right. Maybe this isn't going to go very well. That gut. And like when I was in Jake's room, I was like, oh, I just feel like this is not going to go well today. Go with that. Trust your gut. Okay. All right. Now, initiation phase. If I drop my pressure, we're going to do what we did in Heather's room. We're going to give fluid. Now, she gave LR because surgery likes LR. Us medical people, we like normal saline. Don't get stuck on that. You're not the one ordering it. You're just the one administering it, okay? So normally it's an isotonic kind of thing. LR and NS are both isotonic. You may give some mannitol to help sort of pull, that's an osmotic diuretic, right? Help pull fluid. Now, here's where it gets a little tricky, and this is when Jake's patient's case, they wanted to put him on a Lasix strip because he was so positive, right? And a lot of times when we get consulted and we see them in acute kidney injury, we try a stress dose of Lasix. We might give a big dose of Lasix, like 60 milligrams times 1. And then they got to call me back and tell me how that urine output is. Does that make sense? And if they respond to it, it's like, hey, let's give some more diuretic. If they don't respond to it, why would I give any more diuretic? You guys see that? So you may be at the end of giving that stress dose of Lasix or Bumex. It's your job to follow up and see how they responded to it. So Amber, when you or somebody, no, Sarah Lynn, was it the Diamox? And I said, we got to empty that Foley bag and we got to really see what kind of response we get. And Amber too, right? Didn't you pay? Yeah. We want to see what kind of response from that diuretic they get. Don't leave urine in the bag. I don't know if you already have 400 floating in there. Did it spill over? Did I really get a brisk response? They want to know exactly how much they should put out after that dose. You guys get that? That's a really important thing because they're going to make a decision whether to give more or not. Okay. Chlorpheniramine, I haven't seen that much. That's an IV drip. We don't order that, but it also can help with renal perfusion as well. If urine output drops below 30 an hour, start to consider ATM. Certainly you're treating the cause. If I am bleeding, I'm a hemorrhage, you're going to give Paxils. And then acute glomerulonephritis, it's an inflammatory response, so you're absolutely going to give steroids. Okay. Again, that's not up for you to decide. That's just up for you to prepare. Osmotic means it's going to pool in. So like your cerebral edema, when you guys learn about it next week, I think Jill's talking about cerebral edema. It's a great drug for cerebral edema. So it's going to pool the fluid in, okay, and pee it out. Him, if he had increased cerebral perfusion, yes. It can otherwise, but more often than not, I see that the mannitol is given with like intracranial cerebral edema. More often than not. We don't use it that much in the renal world. I do a lot of the loop diuretics, those kind of things to help pull fluid off. Again, option up to whoever finds what article that's great that week. So, all right. Now, you either fix them, or now we're into the oliguric and uric phase. So now we're not making urine, right? Or minimal, 400 or less. Please don't study those days, hours. No one gives a hoot. It's just some background information. You need to think like a nurse. How? Okay. Oh my God, my patient's not making urine. What should be the first thing in your mind that comes up? Okay. Okay. Am I thinking fluid overload first? So your brain goes, oh my God, they're not making urine. Where's all this fluid going that I've been blowing into them, right? So now we've got to think about, and yes, the blood work is correct too, so we'll get there. But now we got to think about, I just blew in 21 liters of fluid into a patient. How are we getting it out? How are we getting it out? And how are we preventing further fluid volume access? And yes, we are definitely going to have to look at all of those electrolytes. That's why your patients get Q12-hour blood work. Jake, help me out with that. We tried. We sat down and scrolled back. I am telling you, I don't care what patient it is. When I worked in the ICU for 13 years, I weighed my patients every day. Whether it was ordered or not, didn't care. Because I think I got yelled at once by a nephrologist, like, why isn't the weight done now? You know, and I'm like, well, I want diet. He wants that weight. So it should be good. But we couldn't find it. We went back to admission, and I think he was 226 on admission, and he's up to 259. But is the bed accurate? Do we not? I don't know. So it should be a daily weight. Hands down, you guys, daily weight. Now, we'll talk about how to treat all of those alterations in electrolytes. And then metabolic acidosis is going to be our problem, right? So we'll talk about how we can fix that as well. The longer you're in oliguric and uric, the longer you're in that phase, the more chance of having chronic changes is there, okay? So fluid restriction. Now, you never have to say, I really think they should be on a 1200 fluid restriction. The nephrologist is going to order it. How they make that judgment is, they look at the urine output and then they do this insensible loss and then they decide. More often than not, I see everybody going to 1,000 milliliters. Have you seen dry trays? Which totally sucks because there's nothing to drink under their meals. We're dry trays. And I get yelled at every time I go in there. And I'm like, I didn't order it, the nephrologist did, but there's no fluid. That's how restrictive they are. So it's very important that you think about and how you educate your patient on what that fluid restriction looks like. Strict diagnose. Cannot tell you how much it drives me crazy. I order a Lasix, I come in and nobody has a urine output form. How do I know that how they responded to the diuretic? I mean, that's common sense. Doesn't even mean if it's ordered and I have ordered it and nobody's gotten intake and output. Please, 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 that really helps us make a decision on what to do next with the patient. Make sure that you're getting your strict diagnose and the daily weights. Because that's going to tell me how well my treatments are working, right? Back to this guy that's 21 liters positive. Shouldn't we weigh him daily to see if he's coming down instead of going up? We couldn't find daily weights. 3, I think we found 3. Yeah, I mean, no. Okay. I'm gonna spend some time on this one because this is probably one of the things that everybody freaks out the most about is this high K. And because I can't excrete the potassium level is definitely gonna be high. And they're gonna be acidotic. If you remember, when I'm in states of acidosis, K gets bumped out of the cell, pushed, and H tries to go into the cell, right, to regulate that acid base imbalance. So that's when your K is high in metabolic acidosis. H is trying to hide in the cell. K gets bumped out. So the issue is a chronic renal failure patient or chronic kidney disease, or more so end stage, can tolerate the elevations in K better than you or I that don't have any problems. Everybody got that? So if you said, oh, Lorraine's potassium today is 8, I hope you're all having a seizure and like want to do something very, very quickly. I've had end stage renal people who skip their treatments and come in and their K is 8 and they look better than me. It's individual. But it's important that you pay attention to that. So anytime you treat something, potassium, calcium, magnesium, always ask, when's the next time you want me to look at this? Because I can't remember who I was with yesterday. I'm like, why didn't they follow up and see if this was getting better? Did. Yeah, he was toxic when he came in and we're still giving the dip. And I'm like, what? I said, maybe they changed the dose, but shouldn't we follow up and see if we're now in a better range? Okay. All right. So more often than not, this one right here, and that's why I have it first. 50% dextrose, regular insulin. No other insulin can be IV. Regular insulin. Bicarb, Jill says that St. Joe's loves to use bicarb. I see my guys maybe once in a while, or if they're severely acidotic. And then the calcium, more often than not, we give gluconate, although down in SI they give chloride. So again, it's preference. The calcium is to protect the heart from the effects of the high K. It helps the heart contract, right? Because when the potassium level is high, the heart says, listen, I don't feel like working. So you may give an amp, you may give half an amp. I'm not diabetic, so if you came in and just gave me 10 of a regular insulin, you might drop my blood sugar, right? So, and glucose also helps facilitate moving that potassium back into the cell. Here's the problem with that. It is a Band-Aid, it's a temporary fix. We need to do something a little bit more permanent or a little bit more effective, because as we go along in the case, we come back out of the cell again. Yeah. So you might give several treatments of this insulin D50 until dialysis can come and dialyze the patient. Do you guys get that? So it's a temporary fix, and it makes me feel better when I do it. But I know that it's going to go back to being acidotic again and the potassium being up. So I would give that treatment emergently. Okay. So that acute kidney injury patient who's got the spike in my young kid that I told you that seized, his K was 8 and he cardiac arrested. That's what they did, and then put him on dialysis. Below, depending on what your level is, you don't need to determine that. So don't obsess about like if it's 5.8. You don't need to determine that. That's up for the doctors to determine. But you might see low CalMet. Anybody give that this semester? Yeah. 10 grams once a day? Yep. Okay, so you might see low CalMet. And that might be somebody with a potassium of 5.9. They're asymptomatic. We don't need to get aggressive with messing with insulin and all that stuff. So you might see low CalMet. And that's why I put not for emergent treatment. Not for emergent treatment. Okay. Or you might see Veltassa. Now I see low CalMet here, but maybe in another hospital you might see Veltassa. Again, somebody with a slight, when my dad was at home and his K was 5.9, they gave him K-Exolate. He had to drink it. Some people are still old school and use K-Exolate, not exchanges sodium and potassium in the bowel, and we excrete it out. So you may see K-Exolate. Now, nebulized aerosol, my husband gets really irritated with this one. There is a side effect to albuterol that it drops your potassium. So if you have something, so if you have somebody that's getting like albuterol treatments frequently, take a look at the potassium, see if it drops it. It's a treatment that they'll give in the ER. My husband goes, all right, and he'll give 3 treatments right in a row to try to drop the potassium. Yes, that's a side effect to albuterol. Causes hypokalemia. Don't really do that in the ICU. We really do the dextrose and then get somebody here for dialysis. And then last is renal replacement therapy. So let's review some fluid and electrolyte. How do I know somebody's in metabolic acidosis and they don't have blood gases? Thank you. What will my venous CO2 be? Low, 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 low. Or venous CO2 of 12. Venous CO2 of 18. Now, in the ICU, I hope they have gases. If they're severely acidotic, I'm hoping that that's what they do. pH, of course, is going to be on the acidotic side, less than 7.5. Anion gap. We only measure the anion gap in states of metabolic acidosis. There's no other reason to come and talk to me about an anion gap if they're not metabolically acidotic. Everybody got that? So don't calculate an anion gap if they're not metabolically acidotic. Now, you'll see these patients, and like our DKA patients, I see this all the time, they're severely metabolically acidotic, will be breathing 40, 50 times a minute. Please don't sedate them. That's their compensatory. They're doing Kussmaul's to blow off that acid, to balance out their pH. Because what's most important is to have a normal pH. You can have alterations in the venous or the PCO2 and the bicarb, but what's most important is a normal pH. You may put them on a bicarb drip if they're that severely acidotic. DKAs, I see that a lot because they'll come in and they'll have a bicarb of like 4. And you're like, bah! So they'll put, long story short, bicarb drips can sort of make respiratory acidosis worse, but I don't want to talk about that. So I don't see bicarb used as much. Like years ago, we put bicarb drips on everything. Anybody run a bicarb drip this semester? St. Joe's? No. Yeah. Okay. It just depends. It depends on the physician. So, all right. Now, so I've been in the ICU. I've been, and in that anuric oliguric phase, it's really getting them through. It's not fixing the kidneys, right? It's really getting them through until the kidneys sort of fix themselves. When you aren't giving any more diuretics, or you're working night shift and you're like, oh my God, I've emptied this Foley like 3 times, is the diuretic phase. Now the kidneys are starting to say, hey, I think I'm going to start to work. So now we dump everything out. So just when you remembered in the oliguric anuric phase that we fluid restrict, now we got to give back fluid. So I always say that kidney injury can be very confusing because one day you're restricting, the next day you're giving fluid. You got to know what's going on with the patient's alcohol. And as you can see, up to 4 to 5 liters a day, they are just spilling. The kidneys can't filter, so it's like opening the Hoover Dam and everything's spilling out. Electrolytes. Remember when we were treating the high potassium? Now we're going to treat a low potassium.
So even the potassium gets filtered out of that.
Everything, because it's like they're still fragile. They have no idea what they're doing, and everything gets dumped out. So just when you think, oh my God, I was given insulin and B50 the other day, now I got to give potassium back. Again, based on your lab values, based on your patient, you got to know. Oh yeah, he put out 10 liters of urine last night. That's not normal, right? So so they're beginning to heal. They can't concentrate urine, okay? They can't, so they're just spilling everything out. So what am I worried about? Yeah, now I'm worried about dehydration. The other day I was worried about him being in fluid overload, but now I'm worried about dehydration. Do you see how quickly this can change? Because I said acute kidney injury can change, right? You can reverse it. So at this point, you might be hanging potassium. You might be hanging IV fluids because I'm dumping urine. I have to keep up with what I'm losing, right? That's why your intake and output is so important. All right. And then during the diuretic phase, that makes sense, right? I don't care which part, where you're at with acute kidney injury, always pick daily weight. Always pick daily. Okay, orthostatic BP, because we really want to see with that fluid loss. Strict, and always pick strychnine too. That's key. We're gonna get electrolytes, and again, not up for you to decide how frequently, it's up for you to just get them and report them. Okay? And then we might, what will show up? Let's do a little Jill review. What will show up on the monitor is my potassium. Like what? Don't be general. No, PVCs. So I might look up and go, whoa, they dumped out 5 liters of urine, and now they're throwing PVCs because I've lost potassium or magnesium, right? Again, assess. Constantly be vigilant in looking at what's going on with your patient. Now, recovery. And I told you my young man at home with normal kidney function. Urine creatinine were normal, was off dialysis, making urine. However, that 3 to 12 months, he's very fresh. So he shouldn't come back in and get a CAT scan with a guy, right? He should have that conversation or medications and say, listen, I had a severe episode of acute kidney injury. I don't want to take that med. I know it affects the kidneys. So it's really important that you educate the patients and say, you know, anytime you're going to a doctor or anywhere, let them know that you had an episode of acute kidney injury. And then, of course, they're going to follow up with nephrologists, outpatient, to make sure that we're still headed in the right direction. All right, general interventions, avoid hypotension, common sense. Strict dyno, strict dyno, strict dyno. I can't say it enough. You don't just go, they put out, there's 17 liters negative. No, you gotta call somebody, okay? Reduce exposure to nephrotoxic agents. So again, there's aminoglycosides, NSAIDs. You'll see one of the first things that we do when kit renals consult, they'll say hold NSAIDs, hold ACE inhibitors, because those could cause kidney failure. Okay. So you will see some of the medications being held if they're not acute kidney injury episode. Monitor labs, closely watch INO. Drug therapy, depending on what phase they're in. You guys get me? So if it's like oliguric, anuric, I might give a diuretic. If they're in a diuretic phase, I might give fluid and potassium back. You gotta know what phase they're in. Okay. And then we're gonna talk about intermittent versus continuous. Who's seen continuous hemodialysis in the ICU? Anybody? Okay, so we'll talk about that. And that's the only place they do it. They don't do it anywhere else. Continuous is the ICU. Okay. And we'll talk about the different types of dialysis, what you could do. So this is from your book. And I actually got to meet her, Deanne, went to one of her seminars. And I really like, if you're a concept mapping kind of person, I guess. I really like this diagram. It really sort of breaks it down nice and organized, I guess. So if you want to study from this, or if Jill has one that's better, you know, up to you. All right, questions on acute.
So how do the types of AKI and the phases of?
So remember that the types are just what was the cause? Was it before the kidney? Did something directly damage the kidney? Something post the kidney? The phases are, where are we at with this acute kidney injury? And more often than not, if we're in those phases, it's probably going to be intrarenal, because if I fix it, I move on. If I don't fix it, I go into intra, right? Because it's been prolonged ischemia. So that's one of the first things that they do is decide whether it's pre or intra. So the phases more often than not would be with your intrarenal. Yeah. All right. So chronic, here's the beauty of chronic. It's the same damn thing, you guys. All right, let's see if this works. Yeah, it does. Okay. All right, so chronic. What did I say acute is? Yes, I did done. So guess what chronic is? not reversible. That makes sense, right? So we're gonna spend a lot of time on medications because that's one of the mainstay treatments for chronic kidney disease. Now, you need to understand not all chronic kidney disease is kidney failure. Everybody got that? I'll say that again. Not all chronic kidney disease patients are in failure. How do I determine that? GFR. That's exactly right. So my dad is chronic kidney disease 3B. Don't get excited about that. I'll talk about that in a minute. And he's been there for years. Now he's never going to be chronic kidney disease 2, right? Because he's caused that damage. But we don't ever want him to get to 4 or 5. Do you guys see that? So wherever we are at, we'd like to stay there. If they already had chronic, we'd never like to be there in the first place. But if we are diagnosed with chronic kidney disease, we don't want it to progress anymore. Everybody got that? Does that make sense to you guys? So there it is. Function does not recover. Slow process. So remember, Nikki Gentile's walking around Walmart in stage 3B. You wouldn't know it, but he is. I know it because of his lab work. Now, this could be acute, like if I get in a bad accident and I have blunt trauma to both kidneys and I damage both kidneys. Do you guys get that? That's all that that's saying. Absolutely 100% need to know this slide. And the reason why is then you understand. So do you see why I hate 60? Greater than 60. I already could be a 2 or 1. I hate that. My sister, she was 50, she's 58, and diabetic now, and healthy, but diabetic. Went in for some blood work. Her GFR was 31. And I said, whoa, I made her like quit her doctor. I made her go see my doctor that I work for. And it was because she was severely dehydrated. But this is like the 4th time that her GFR has been down in the 30s. And I'm like, Chris, I don't like this. So she's now following with the nephrology yearly to make sure she doesn't get worse. My dad's diabetic. My sister got that gene. She's diabetic. And now we need to pay close attention to her kidney function. So without knowing the specific, remember I said GFR is about 125? Remember that? So I could, if I'm 91, I could be in stage 1 already. Do you guys see that? I don't want to be in stage 1. I want to be perfect, right? So this greater than 60 means nothing to me. Malproduction GFR is 60 to 89. So hypothetically, a question would be something like, patient has a GFR of 88. What stage is the patient in? Boom, 2, right? Makes sense. And yes, that's a knowledge question, but I want you to know. Okay. I gave you a test question. There you go. But that's not the one I'm going to give you. So 3 is broken down into A and B, but we're not even going to talk about that there because you don't need to know that. 3 is a moderate reduction. So now that's where that greater than 60 comes into play. So that's 50% of my kidney function's gone at stage 3 because I'm down to 60 instead of 125. Do you guys see that? And then 4, again, I'm not on dialysis till I get to a GFR of 15 or less. Everybody got that? So just because my sister had a 31, they're not sending her to dialysis today. We're watching it. Now, can I acutely go down to a 15 right away? Yeah, cardiac arrested. I was hypotensive. I might start dialysis, but again, it's acute kidney injury and I might get better. This is over years. Okay.
We had a patient, Caitlin and I actually. His GFR was like 31.
Mhm.
He was going down to get the tunnel cath forward.
Was he acute or chronic?
He was acute on chronic.
Was his electrolytes abnormal? Unstable?
Yeah.
Okay. So it could be an issue when he was in the ICU.
No, PCC.
That's interesting. Unless they have been followed by the nephrologist for years and they finally said, let's just get a catheter and prepare. Now I've had people have fistulas developed, catheters put in and never go on dialysis. So they could have been anticipating it. Without looking at the chart, I don't know.
Yeah, because I just assumed, because I didn't know much about this. and I'm like,
Yes.
Oh, 30 sounds pretty bad.
No. I mean, and again, and it's funny because the two nephrologists that I work with, who I respect the most, one is extremely different than the other. One is, oh, let's dialyze today. The other one's like, let's just wait and see. So everybody's very different. So it could have been that particular nephrologist. But normally,
A laundry list of like.
Yes.
Heart failure and just like.
Yes.
all kinds of
so that's a chronic thing that's probably not going to change, and they're anticipating he's just going to get worse.
Yeah.
And if he's been in the hospital repetitively for those kind of things, they might be like, let's just be proactive. Yeah, makes sense? That makes sense to you guys? All right. What do you, oh, it's right there, damn it. Okay, never mind. Two number one causes, diabetes and hypertension.
You know, both.
Yep. Not uncommon. Interesting enough, my dad's been diabetic, but he's not hypertensive. So he doesn't have the second, but you're absolutely right. You'll see them sort of dating and go hand in hand with the patient. So we need to get our blood pressure under control, right? And we need to get our blood sugar. This is what calling, oh yeah, my blood sugar was 180 today, and I'm about ready to have a seizure. I'm like, oh, no, honey. So you need to get those both under control because we don't want to progress. Okay, we don't want to progress. You may see autoimmune lupus. I had a nursing instructor who died of renal failure from her lupus. Okay, so you may see autoimmune. I had a patient that was rejecting the second transplant that he had. So transplant rejection, he got acutely ill and then was having some rejection issues. Harmful actions of drugs and toxins, we kind of talked about that already. Chronic NSAID use, not overdosing, but chronic years of NSAID, that's what they're talking about here. Remember I said I told my mother I wasn't driving her to dialysis because she pops Advil like M&Ms. So it may not be an overdose or an intentional boom, all these medications, but it can be a chronic situation, chronic use. Ischemia, we already talked about obstruction. Mechanical damage could be just like a trauma. All right, so this picture, this slide, remember the lady that I had, or the guy or whoever with all the other thing in the kidney injury? It's the same. Okay, so it's all the same. Make sense? I can have pericarditis and acute or chronic with the high elevations of the BUN and creatinine. I can be hypertensive, right? Because I'm not making urine. I could have high lipid levels. I could be in heart failure. You just said that, didn't you, Nikki? Didn't you say that they were heart failure patients? So all those changes put next to this, same as the body that I gave you in the other slide. So we're going to talk about how we treat all of these alterations in a chronic situation as well. So same exact, no different. So if you remember me, now this tachypnea and hypernypnia, I can't even say that word, is due to the metabolic acidosis. Small respirations due to the metabolic acidosis. They are chronically anemic, so you might think they got to be on something. That osteodystrophy, remember we talked about that? Due to the alterations in calcium, phosphorus, bone pain. And we can do a urinalysis and look for different kinds of sediment, and we can tell the difference between the types of acute kidney injury. And if we're spilling protein in blood, that's one of the big diagnostic things for chronic kidney disease is proteinuria. That's what the nephrologist is looking for. How much protein is in the urine? Yeah, okay, there are people greater than that. So it's significant. So just depends. And we talked about that yellow-green skin as well. Again, all of this, same as acute kidney. There's no difference, okay? So psychosocial. Imagine being, I think he was 85. And they said, oh, we need to start you on dialysis this week. The man just cried. Just cried. he was an uncle of one of the faculty members over here. And I remember this day clearly. And he's like, oh my God, what am I gonna do? I'm like, how am I gonna get there? How am I gonna get there 3 times? This is 3 times a week. What am I gonna do? He was very, very overwhelmed. Could you imagine that? Like you have to totally, oh, I wanna go on vacation. No, I need to find a dialysis center. So there's a lot that goes through their minds. So of course, a lot of anxiety, especially if you don't know what's going on, right? What kind of coping style do they have? He just felt like he just wanted to be with his wife and be at home. He ended up living about 7 more years after that. He did end up starting dialysis. But then it was a chronic back in the hospital, back in the hospital. Do I have a lot of family support that will help? And we do. Do you guys know that you can do dialysis at home now? Chemo dialysis at home. I told a patient he was a liar. He was 31 years old and he said, I do my dialysis at home. I said, no, you don't. His wife's sitting next to me. She's in the ICU. He goes, no, they train. I go, no, you don't. And she goes, Marie, we were trained. They had to go to Cleveland and he does his dialysis at home. Chemo dialysis. I didn't say peritoneal. So it's an ever evolving kind of thing. And he was young, so he wanted to be able to do that and still work and do all these other things. So he and his wife were trained. They had to go to Cleveland, I can't remember how many times, to learn how to run this machine. So what kind of social activity work? Body image could be if you have, when you get into peritoneal dialysis, you have a catheter sticking out of your belly, you have catheters and testes sticking out here. It was in level 1. Level 1 has, her dad has a fistula that sticks out this far. I've never seen a fistula that big. I was like, oh.
Is that what because I have an uncle who gets dialysis, and he has like bumps in his arm. Is that
Yep,
from that?
yep. So put your hand on it.
Arm.
Yes. Because they get occluded very easily. So then this one goes down, so we go up here. And this one goes down, so you'll see that, and finally it'll go to a catheter or something like that. But if you put your hand over it, it should purr like a cat. That's filling the thrill. And then you take your stethoscope and you listen to it.
It sounds so
It's swoosh. It almost sounds like a really terrible murmur, like very loud. If you don't hear anything, and we'll talk about that with dialysis, then we got to call somebody because it's depleted. Yeah, but I've had people have repeated. And then sexual activity, maybe the peritoneal could be kind of challenging. There's usually 2 liters of fluid in their belly. It'd be very uncomfortable. Do you guys see that? So definitely could be an issue as well. All right, so just like acute kidney injury, we're going to do lab tests. And we're going to do BUN, creatinine, and GFR. And honest to God, there's a formula for GFR, and I've never used it. Dr. Navretti will in his head and throw out some numbers at me, and I'm like, I don't know how you just did that. But there's a formula that they can calculate that GFR. To get that, instead of that greater than 60 crap that I hate, he can get that number based on age, gender, big long formula. No one's asking you to study that. No one's asking you to study that. Already talked about doing that ultrasound of the kidneys, x-rays, taking a look to see if there's any kind of issues. See how this is repetitive? Now, I kept this is from one of our old books that we use, but I kind of like it. I'm a table kind of person, so it makes it easier for me. I want you to put next to that creatinine BUN GFR. The GFR is going to go down, right, guys? The creatinine and BUN are going to go up. And even more reliable than the creatinine is our GFR. You see that? So we, when I first started nursing, we never even reported the GFR. We never did that. That never came up on our lab. So we're paying more closer attention to that. Your sodium, I want it to be variable. So I want you to put the words variable there. It says hypernatremia often predominates, but let me just say this. I'm sitting at home, drinking a ton of water. Can I dilute myself out? That's why I want you to put variable. It could be depending on, maybe you can put that in caps, depending on fluid stats, right? Depending on your fluid stats. If I'm fluid volume excess, I might dilute out my sodium. Who had low sodium yesterday? I'm trying to think of who I gave sodium chloride added. Yeah. Okay, so pay attention to the fluid volume stats. Potassium, as my kidney function decreases, so does the excretion. So I'm going to be chronically hyperkalemia. Chronically hyped, so I put it in. I'm an arrow person. Calcium and phosphate. Now, the minute I tell you this, you're gonna come back to me and say, I had a patient. Normally what we see is a low calcium, because remember I told you we can't activate that vitamin D. And a high phosphorus because I cannot excrete it. Now, if I have other things going on besides my chronic kidney disease, infection or something else, those could be altered in other ways. Does that make sense? But more often than not, if we're just purely talking chronic kidney disease, calcium low, phosphorus high. Right? Don't go to clinical next week and come back and, well, their phosphorus is low. Okay, well, they were septic too. So it's really important that we're just thinking about what that renal failure patient looks like. And then they're going to be chronically metabolically acidotic. Anybody have a patient that was on sodium bicarbonate tablets? Yeah. All right, so some collaborative problems, fluid overload, and then we can segue into pulmonary edema, decreased cardiac function, with potassium, or I have heart failure. And then weight loss, maybe they're not eating. Now, just because their weight is up doesn't mean that they've gained weight. It just is fluid. So it could be fluid. Remember, all these patients are at risk for infection. The potential for injury could be due to, remember I talked about those spontaneous fractures, to the renal bone disease. Sitting at the sink, washing, and I break my hip. So it could be that. It could be due to their low platelet count. Fatigue because they're chronically anemic. Okay. Anxiety, we talked about all those things. And then depression because I'm stuck going to dialysis 3 times a week. So what are we going to do? Here's what we're going to do. All of these things, we're going to break it down by each one and how we fix those problems. Very complex disease process. A lot of systems affected. Remember the body. So now we got to treat all of this. Okay. So fluid volume first. And oh, I have it bolded. Daily weights and strict diet of. It seems so simple. It seems so simple, but it's so important. Okay. And then if we're thinking fluid, and we don't want them to be greater than, do you see that 2 pound overnight? And I think in Jake's case, his patient looked like he went up 10 feet. Was it 10 pounds overnight? I'm like, wait, what? You know, what happened? So really important that you pay attention to that. Looking at the chest x-ray. What does the chest x-ray look like? Does the chest x-ray say increased fluid? Okay. All of these things, neck vein distension, your vital signs change, heart and lung sounds, S3. You know this, you guys. I'm just repeating. S3, S4, crackles. Okay. The hardest part of this, and I'm sure as students, patients did this too, is enforcing the fluid restriction. They're like, hey, can I have a glass of ice? And you're like, that's like the 15th glass of ice. So it's really hard. And I had a patient that was mad at me about the dry trays. I said, all right, I'll negotiate with him and see if he'll let you have at least a cup of something on the tray. Very hard. Can you imagine me on a fluid restriction? It wouldn't happen. You might as well just dig a hole in the ground and throw me in there. Strict dyno again, maybe renal replacement therapy. Sometimes they'll just pull fluid off and not dialyze if I have excess fluid. And then really educating you guys. This is when I come back in. The lady said, oh, I was sitting on the porch. It was beautiful. So I drank 2 liters of lemonade, Minute Maid, which has salt in it. Yeah, that's great. And ended up in heart failure. I'm like, well, that's probably not a good decision. So really maybe getting dietary on consult, having people, I had a patient that asked me the last time I was on call, he said, can you get me the dietitian? Because I keep coming back in here. I said, yes. I put in a consult for him to have the dietitian come and talk to him because whatever he's doing at home isn't working. Okay. Preventing pulmonary edema. So pulse ox. Check your pulse ox. Listen for those crackles. Are they coughing up stuff? Are they restless? Because remember, One of the first signs of hypoxia is restlessness, right? Start taking their clothes off, doing funny things. I only saw one person with pink frothy sputum and they were intubated, so it's not everybody talks about it, but it's not the most common thing that I've seen. Put them in high followers. If they're making urine, you may give a stat dose of Bumex or Lasix if they're making urine. If not, we may be calling the dialysis nurse out at 3 a.m. to dialyze this patient, and we've done that. Okay. Vital signs, blood sugar, or not blood sugar. Breath sounds. Oh, for God's sakes. Breath sounds. That BS is not bullshit. It's breath sounds. Breath sounds every 2 because we're trying to figure out that pulmonary edema. Looking at the chest X-ray. Why do I want to give morphine, nitroglycerin, and oxygen? Deb Phillips taught it. Mona for pulmonary edema, right? So the morphine, it's not for pain. It's decreased venous return. Same thing with the nitroglycerin. And the morphine can help with that air hunger too, with that pulmonary edema. So, you go in, and I'm like, I got morphine. They're like, well, I'm not in any pain. I just can't breathe. Well, it's to help them. Okay. And then, of course, oxygen.
You said nitro decreases venous return.
Oh, yeah. It does some afterload reducing as well. Your blood pressure is going to drop. But the purpose of why giving nitro is to help decrease venous return. So we're not dumping a bunch of fluid back into the heart and making it harder for me to breathe. Yeah. All right. One of the first things that I look for if I'm clinical with you guys is an echo. Everybody gets an echo. It's like everybody gets an echo. So you really want to know what that ejection fraction is. Okay. Anybody get an echo on their patient this week? What do you got? How much was it? 55 to 60. So pretty decent. 30. Oh. It came in heart failure, I assume. Yeah. Okay. So hers was 30. Anybody else?
Mine gives you 35.
35. Okay. So I want you to think about those patients. What did they look like physical exam wise? Short of breath. What else?
Our guy had like drains for his pulmonary.
Did he have perfusion? Because the drains, we wouldn't drain for pulmonary edema because it's in the alveoli,
Oh, so it is plural.
which is a common thing. So that's why we look at, because what happens is just like in your belly, fluid can leak out into that pleural space. If I have chronic heart failure, pleural effusions are very common, very common. So yes, we can drain those pleural effusions. What else? Give me the typical heart failure stuff, guys. Do we have a BNP? What was your BNP? Do you remember? 70,000. Now you're talking, guys. Do you guys see that? Make those connections. Did they have edema? Crackles, neck vein distension, fluid volume excess, all those things that go along with heart failure. So we know we've got a crappy ejection fraction, right? You said 30, 35. What do we need to do? Contractility, right? What do you want to give me? What do you want to give me?
Right?
Yep, like what? Ditch, butamine, if it's an IV, yep. Now, the other thing, dopamine, not so much, because dopamine can be, make the heart rate go up and make the heart work harder. The other thing besides the inotrope, why do I like ACE inhibitors? And both, right? And that's the gold standard, is to go home on an ACE inhibitor with somebody with heart failure, because it decreases afterload and preload. One pill instead of having to take 2. So that's a beautiful drug. Problem with this, it can make the kidney function worse. So we've got to watch that. One of the side effects to an ACE inhibitor is hyperkalemia. Did you write that down on your med cards? Hyperkalemia. It's one of the first drugs we stop when a patient comes in with high potassium. ARB's same situation, not so bad as the ACE, but ARB's sort of in the same situation. And again, depending on if I've had an MI in the past, I might be on a beta blocker. Calcium channel blocker if I had rate issues like AFib, right? Cardizem for AFib. Yeah, I've seen it more with the ACE, but yes. Yes. And then catapress, this is the old school, but big gun for blood pressure. When you find out that your patient's on catapress, they're probably on 4 other things as well. Because they're just sort of a resistant high blood pressure patient. And then there's your positive inotropes. What's a normal DIG level? 0.8 to 2. And then when would we alter the dose of digoxin? Well, not alter the dose. We would probably hold it, right? If the heart rate's less than 60. Say it again. What about potassium? So if the potassium's low, we need to treat that low potassium. Coumadin? I haven't held it because of Coumadin. I forget why I was asking this question. What did I just ask? Did you?
Or are we gonna adjust the dose?
Oh, yes, thank you. I'm back on track. Nope. People, what am I talking about? Kidney failure, right? Kidney disease. You gotta alter the dose in somebody who has decreased kidney function. They will become toxic. So have you seen people get it Monday, Wednesday, Friday, Tuesday, Thursday, Saturday? They're gonna alter the dose based on their kidney function. Okay, oh my God, daily weights everywhere. If you don't take daily weight, I'm gonna hurt. Now I gotta make a test question. Okay. Daily weight, intake and output, blah, 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 blah. Now, please do not give diuretics to somebody who's end-stage kidney disease, who's on dialysis, who makes absolutely no urine. Would that be a waste of your time and theirs? Yes. So they have to make some. Okay. And those are all loop diuretics right there. We're going to be on a sodium and a fluid restriction. Common is about 2 gram sodium restriction, sometimes 1,500, sometimes only 1,000. Not for you to decide, for you to enforce. And then maybe some dialysis, and then frequent oral hygiene. Their mouth's going to be dry, we're fluid restricting, all of those things. So make sure that you give them like, I don't even know if we have the glycerin swabs anymore, but we're going to do mouth care frequently on this patient. So same treatments that we talked about with the acute kidney injury, we're going to do here. Remember that the K-Xylate and the Valtessa and the Localma, probably not somebody that's acutely up, we're not going to go, oh, here, drink this K-Xylate for your potassium of 10. Okay, you guys get that? So again, it's not for emergent treatment, but it might be something that because we know I chronically have a high potassium, I might be on K-Xylate like once a day at home. You guys see that? Not for acute, although we used to do K-Xylate enemas. Patients couldn't drink. Probably the insulin, the D50, and the calcium. Would you add calcium to that on the side? Yeah, there's a calcium gluconate right below. Remember, temporary fix. I need dialysis to come in and clear off that. Now, if it's just one-time elevation of potassium, we might just give a dose of something and see what happens, right? But if it's chronic, we might do a Valtessa at home, or Localma once a day at home. We're going to do acute with the insulin and the okay. So we need to pay attention to the albumin, hemoglobin, and hematocrit levels. And I have the word stable there, but that means that they need to be within range. Maybe a hemoglobin greater, that's not a measurable thing. That's very general. That's a word. Hemoglobin 10 or greater, right? Albumin, you really want albumin to be normal. So no one is ever going to ask you, is it 2/3 or 1/3? But you can see we want to have really good sources of protein. The dairy products that has next to that, we need to limit. Because if you look below, it has phosphorus. So that means I can't drink a gallon of milk a day. I might have a glass, but I gotta limit it. Do you guys see that?
There's a question about that. So the reason why they can have protein is for a higher amount of protein is because they're getting dialysis.
So it's not higher than you are on normal. You want high biological, really good protein. To answer your question, compared to meal, you lose more protein, so they have a little bit of higher allowance for protein compared to other people who lose the protein. Not so much as dialysis, hemodialysis, but peritoneal. They have a little bit higher amounts that they can consume. All right, so again, not for you to decide, right? First thing that I would do though, if I had a brand newly diagnosed unstable, is I'd get a dietary consult. Make sense? I'm gonna ringy ding her and say, hey, I need you to come out and talk to them about all the changes because this is a very difficult diet to follow. So let's go to phosphorus. This is the part that makes me the maddest about if I ever get kidney failure because there's all my favorite stuff in there. Particularly chocolate, peanut butter. Again, that doesn't mean I can't have a piece of chocolate, but Lorraine doesn't know what one piece of chocolate is. She likes to eat the whole box. So I really have a hard time limiting my chocolate intake. So that's going to be hard for me. And you see the whole grain. So the white pasta is better than the whole grain because the whole grain has higher phosphorus. Believe it or not, everybody wants to see white pasta. I can have milk, but limit it. Same thing with cheese. Why colas? I can't have Coke. I can't have Dr. Pepper, but I can have Sprite. There's higher phosphorus in the dark pops. Higher phosphorus in the dark pops. So I could have ginger ale or Sprite, whatever else is out there. Okay, now not only do we have to limit our protein, now we got and limit our phosphorus, now we got to limit our potassium. So here's the interesting thing, and I never do this because we always were like, we'll have the salt substitute because I'm in heart failure and I can't have salt, right? But the salt substitutes are high in potassium. So Mrs. Dash is fine because there's absolutely no salt in Mrs. Dash. But the salt substitutes high in potassium. Also, those very dried fruits like apricots, they're higher in potassium as well. Now, I love a salad a day. That doesn't mean I can't have it, but I can't eat it for every single meal. Make sense? So really limiting that. Citrus fruits like your orange juice, those kind of things are high in potassium. All right. Anybody know anything else that's high in potassium? This is another reason why I hate this diet too. Two of my favorite things. Don't say banana. I hate bananas. They're terrible. I think they taste like snot. My husband eats one every day, and I'm like, ugh. Cantaloupe and avocados. Those are my favorites. They're high in potassium. Now, NCLEX isn't going to ask you bananas because everybody on God's green earth knows that bananas are high in potassium. They're going to ask you something like avocados, potatoes. Oh my God. So my dad, when his kidney function got worse, I said, Dad, you're going to have to limit, the French fries, potatoes, because they're high in potassium. He said, no, I'm not doing that. I said, well, you can get worse. No, I'm not living them if I can't have potatoes. I'm like, okay, eat the potato. I mean, you just watch him have it. But he was like, that was the only thing he was mad about. And I go, oh, you kind of have to watch the pasta too. He goes, no, not doing it, not doing it. So he doesn't follow his diet at all. And I just wash my hands of it because I've tried, he thinks I don't even know how to drop insulin. He asked me that the other day. Do you know how to do this? I said, Nikki, I've been a nurse 32 years. I've been. Your sister does it better, does she? Okay. You can have her do it. I'm not bitter. So, but he's very challenging. I always talk about Nikki. He's very challenging with regard to his diet. Like I spent a lot of time with him. And I can't get him to understand. Now he's 83, so he's doing pretty good. But boy, what a challenge. Sodium fluid restriction, you guys know this. Now I'm not, those are reference ranges that 2 to 4, 1 to 3. And I see more often not the 1 to 3 in the hospital. I've not seen the 2 to 4, but again, I've been acute side, I'm not home side. Do you know what I mean? So again, not for you to decide. The nephrologist can tell you how much salt they're allowed to have. Just know that you have to restrict. So then you have to educate. What am I going to tell my patient? A couple things on this one I don't like either, because then I'd have to restrict that and I wouldn't be happy about that. Okay. Say it again. Lunch meeting. Oh my God, I have lunch. When my husband's not home and cooking me dinner, that's my meal every night. It's lunch, a turkey and sandwich. I'm screwed. I mean, I can't eat. There's nothing that I can eat. So yeah, so lunch meat, processed foods, pickled foods. I'm on a pickle kind of thing right now, Jag. You know how kids are on Jag. I've been eating pickle sandwiches every day now too. Why? I don't know, but it's just something I've been doing. So, I don't ask. So I found these really good pickles and I'm like sort of obsessed about them. Not, there you go. So pickled things, processed things, canned vegetables, canned soups, all of those things, lunch meats, processed meats, sausages, all those things are really high in sodium. Okay. So make sure that you give them handouts. Show them what that actually means. Okay. Preventing infection. So you need to be the proactive nurse looking at the white blood cell count, looking at any kind of puncture wound, any kind of lines that don't need to be in, get them out. When we have a peritoneal dialysis catheter, I'll show you what an infection can look like there. You're going to look at the sed rate. What will happen with my sed rate? Increase, right? So sed rate can go up, but a sed rate can go up for inflammatory disease process as well. So it's not as specific. We want to look at the white blood cell count. And not every patient becomes febrile. So if I started with the temperature of 96, because I'm older, and now I'm up to 99, that could be a temperature. Do you guys see that? So again, looking at the trends for your patients. Preventing injury. Let's see where we're at. Okay. Yeah.
There was something wrong on my slide.
Oh,
Yeah. We got the last version, I think.
no, really?
Yeah.
Stop it.
Like a lot of expected outcomes and stuff.
Oh my God. Does it say full?
Yeah.
Stop it. On mine or yours? Yours says full.
It's a different color too.
Yeah, I always change it. I always update it. Son of a gun.
There's like a lot of things missing that we have to like make sure we read them.
So the acute's old?
We've been doing a lot of writing.
Good. No, that's okay, because then you learn.
Well,
Yours don't have medications.
sometimes we're not paying attention while we're writing.
Well, then I'll, what don't we have? Localma. Because it's new. All right. So what we'll do, good gravy. Good. Then you'll absolutely know them.
But sometimes we can't pay attention to the writing.
Yeah.
What?
That's the
Now,
downside.
just wait a minute.
I'm just saying.
When I went to school, I had to write, and I was able to pay
You guys
attention.
were barefoot too.
Yes, I was in the snow. Now, all right. All right, go to break. And I will fix this. Hell, what did you people wait till now to tell me this? Good little students. Now you're going to remember it for sure. All right, let's take a break.
Well, what do you, I don't understand. Just keep using that one, it has information on it, right?
But I didn't know I'm gonna upload it to your Canvas. I'm gonna use mine, but I'm gonna upload the most current Canvas for you guys. But, I mean, they're very subtle, like, not big changes. Where is,
I just normally, I noticed it because I normally don't have to write this much.
I'm glad that you did. All right. Okay, shame all of you for not telling me I had the wrong thing uploaded. But I'll forgive you.
I thought you did it on purpose, so we had to wait. now.
No, but I like that idea. I like that idea. It was not intentional. It was not intentional, but I like the idea of the active engagement and really writing your notes and what have you. All right, let's finish this up and then we'll just touch a little bit of dialysis and then we're going to do the case study. Okay, does that sound fair? All right, so fair? Yeah, no? Yes, my friend. Wow, what do you guys do when you go back to the bachelor's? Yeah, but they ain't gonna record stuff for you. Could be some, I mean, one of the, well, it depends on where you go. Depends on where you go. Okay. All right, so preventing infection. So you are the proactive investigator to make sure that we don't get infected. Because if I come in and my white cell count was normal and now it's elevated, y'all gave it to me, right? So pay attention to that. Be active, looking at your white blood cell count. Not everybody gets a SED rate. You want to look smart, you can say, hey, what about a SED rate? I mean, but if your white cell count's elevated and you have positive culture, you already know it. I'm going to talk about that peritoneal dialysis catheter on Monday. So that's a big area that gets infected. That's a big problem, peritoneal dialysis catheter. Okay, preventing injury, no pathological fractures, no toxic side effects, and no bleeding. So daily falls scores, daily. You need to know the detailed drug history. That doesn't mean illicit drugs. That just means what are they taking? Look for drug-related complications depending on the drug. Okay. And then if on DIG, give me some signs and symptoms of toxicity. Non-Giovanni, that's everything. But visual halos, yellow, green, whatever. I should say. What else? Bradycardia. Not normally. Not normally. It doesn't affect the blood pressure. Now, nausea and vomiting, I'm going to let you say that because that is the biggest thing the patients complain of. Okay, so that is what I'm going to let you use. But we want to get a DIG level. Remember, we're going to alter those doses. Okay, so definitely, you know, somebody comes in on DIG, and this I was just telling Caitlin, I said, you know, I always go, well, do you think we should get, like I always play dumb. Do you think we should get a DIG level? Great idea. You know, and then they order it and they act like they're so smart. So, but that's okay. I let them think that they are. So, heparin, Coumadin. Now, when we get into the dialysis patient, we put heparin in those lines, but it's only in the lines, not in the patient. Okay. However, if I'm receiving Coumadin because of AFib, you know, could I potentially become more toxic? So we need to watch those PTI and R levels. We need to watch those PTI and R levels. Okay. And then aggressively look for bleeding. Are they bruising easy? Did you put an automatic blood pressure cuff and their whole arm's black and blue now? Aggressively look for that bleeding. Check their stool, check their vomit, check whatever. Okay, this, guys, is what I was talking about with the calcium and the phosphorus. Okay. So this is that osteodystrophy disease. So if you look to the left, here's your phosphate. We cannot excrete phosphorus. Okay. And then it binds with the calcium and decreases the calcium even more. And the parathyroids go into overdrive and say, wait a minute, I got to fix this. Remember I said they have secondary hypoparathyroidism? So you might see an elevated PTH level. The patient might get that blood level. Then, because the body says, wait a minute, I've been chronically low calcium, it pulls the calcium from the bones to try to raise the calcium level. And that's where we have those pathological fractures. Make sense? So our goal is to regulate that phosphorus and calcium level. How are we doing that? Say it again. One of them.
Phosphate binders.
Phosphate binders. Okay.
Will we get supplement?
What kind of supplement?
Oh,
Yeah.
calcium.
Keep, yep. There you go. See, just think it through, guys. Think it through. You got that. So here we go. So what we want to prevent is them to have that bone disease. Is you got to look at the calcium, phosphorus, and albumin levels. Why do I care about the albumin so much? What is calcium? No. About 50% of calcium is bound to albumin. And the other's floating around. That's that ionized calcium. The ionized calcium is a better indicator of what's going on with the patient. So I have less albumin, I have less opportunity to bind, right? So we want to know calcium, phosphorus, and albumin levels. All those goes up. And just like you said, I think Nikki said, or somebody over here said vitamin D. I don't know if it was vitamin D. So vitamin D. Now, these, the calcitriol, the calcijex, and Zemplar can be given at the end of the dialysis treatment. So it'll be given by dialysis. Some patients, and I'm sure you've seen in the hospital, are on D3, weren't they? I know I've given it. Okay. So some patients are on vitamin D at home. Okay. Calcium acetate. So if we have a low calcium and a high phosphorus, we give calcium, shouldn't our phosphorus go down to balance that out? So Phos low is a phosphate binding agent. Here's the thing. You got to take it with meals. If I'm NPO, if I am NPO, I'm not going to take this. I don't have any dietary phosphorus. You guys see that? So it has to bind with what I am eating, and I excrete it through my stool. Okay, so phosphate binding agent, got to take with meals. Now, when I was a brand new nurse, because Foslo wasn't out then, everybody times I thought, boy, everybody has indigestion. Well, no, because Lorraine was stupid and wasn't really focused on renal then. We were giving the calcium supplements to help with that back then. So some patients still take those times. Some patients still take those times. Amphigel or Alucap, I have not seen this much. Here's the thing, it has aluminum, okay? And this you take 1 hour after meals and at bedtime. 1 hour after meals and at bedtime. Renagel, it's not a calcium binder. Give 1 hour before or 3 hours after, but it will bring down the phosphorus level as well. Another phosphorus lowering agent. It's not made of calcium like the calcium acetate, the calcium carbonate. Renagel, that one's easy. Give other meds 1 hour before or 3 hours after. And it should say that on your monitor if your patient's on that. Phosrenal, that one's easy. I think, oh, phosphorus and renal, right? I put that together. Take with meals. I haven't seen that one. I don't know if it's just more expensive. I haven't seen that one used. Probably the most common that I see is Foslo. Have you guys given Foslo? Yeah. That's the most common in the tongue. All right. We talked a little bit about this in acute kidney injury. The patients are chronically anemic. Okay, so they're going to be tired. So what are we going to do is we're going to give back that depot. But here's a caveat, and I need you to circle, highlight, star this. You need to pay attention to your hemoglobin level. if the patient's hemoglobin level is greater than 12, and I have some physicians that say 11, you're not giving it. You guys understand that? So that's a hold. And you go, well, Lorraine, 12 is normal. These patients are not used to high hemoglobin levels. So before you give EPO or Retacrit and Aranesp, you better know that hemoglobin. You guys get that? I'll say that again. Before you give any form of Epogen or EPOIN, you need to know the hemoglobin. Every nephrologist is different. I've seen 11.5, I've seen 12. Your book says 12, so that's why I have it here. But every nephrologist is different. Remember I said 10 and 30, a hemoglobin of 10 and a hematocrit of 30, we're happy. Okay, so if you go in and your hemoglobin today is 15, you don't go, oh, the med's working, let's give it again. You can cause, look down below, thrombotic events. They're not used to such high levels of hemoglobin. That makes sense to you guys? Okay. Watch their blood pressure. Now look at this side effects down here for the Aranesp. CHF, sepsis, vascular access thrombosis. That's your uncle. The repeated. So again, you need to pay attention. That's why you're always checking that vascular access to make sure it's paid as well too. So one of the things, if they don't give me a hold, I ask for a hold. Where are you comfortable, doctor, with your hemoglobin? Oh, I don't want it greater than 11. Okay. Do you guys see that? It saves you phone calls. So if he's ordering something right there, you say, hey, where are you comfortable with their hemoglobin being? Oh, keep it 11.5 or less. Make sense? Any kind of med that should have a parameter, I always ask before they leave. Because I don't want to call them at 3 in the morning and go, should I give this? Shouldn't I give it? Should I do this? I want to make sure that I know exactly where he wants them to be. Okay. Who's given Fairlicet? I know you have. Brown? Testos? No? Nobody's given Fairlicet? IV iron. So one of the things is we're going to probably have iron studies, right, guys? And we're going to determine that they're iron deficient. Because I'm not going to give iron to somebody who's not iron deficient. So you're probably going to actively look for iron studies. And then if we start with the IV, which will be the next slide, the Fairlicet, this ferrous sulfate is a tablet that I can take at home. I know I'm chronically iron deficient anemic. I'm going to be on ferrous sulfate at home because I can't do the IVs at home. So a couple things. Take on an empty stomach. Don't give with antacids. Educate your patient that their stools are going to turn dark. It doesn't necessarily mean that they're bleeding. Add stool softeners because it makes them constipated. Anybody give ferrous sulfate? And if you're drinking it, tell them to take it with a straw because it can sting you too, if it's a liquid. So there's tablets, there's liquid. Actively look for iron studies because you're like, why am I giving iron? Oh, they're iron deficient. Okay. Now, this is what I'm talking about. Nobody gave IV iron this semester yet? Maybe first dose or repeated dose? Did you do the test dose? Okay. So what she's talking about is, I don't know if you're going to have a reaction to the iron. So I've got to give a 25 milligram test dose first. I give that 25 milligram and I see how my patient does. Then I call back to the pharmacy and say, I need the rest of the dose. The total dose daily is 125. So I've already given 25, they're going to send me up a bag of 100, right? That makes sense. And I finish that. And then 8 days consecutively, 7 more. I get 125, 125, 125, 125. You guys see that? Now, that doesn't mean I stay in the hospital for the full 8 days and I get the full 8 days of IV. I might go on ferrous sulfate at home. Make sense? So this is a big thing, allergic reaction. Big thing, allergic reaction. Hence why we do the test dose. And then I want you to look here. If you give it too fast, how fast did you give yours, Claire? Over an hour. So if you give it too fast, you could drop their blood pressure. So we give it slow. and they could feel this flushing, maybe some chest pain. So we give it slow. Okay? Don't ever push it, ever. We're gonna hang it as a anaphylaxis is the big thing. That's why you're doing the test dose. Because you don't want your patient to have a reaction. You call down a pharmacy, say, we gave it 25, she's doing great, not wheezing, not, okay, we'll send up the rest. Venofer, I've seen them do just on dialysis. I've never given. So it's 100 milligram each treatment for a total of 10 doses. Now, honest to God, please don't memorize 100 milligrams times 10 treatments for total. Please don't memorize that. Dialysis nurse is going to give this. Again, anaphylaxis. So, if they go to dialysis and they ship them back to your floor and they're having an allergic reaction, you can suspect maybe it's the iron. Patients will be on folic acid and B12 as well. And we'll probably have a B12 level just to see what the patient's at. Okay. All they help with red blood cell production and maintenance. Reducing anxiety, we kind of talked a little bit about that. Again, educate. Most anxiety is, don't you guys feel that way? I don't know what the test is going to be like. I don't know, right? So giving them the information and educating them about their diet, about what to expect during the treatment, and being supportive to them is so important. This is a major change in their life. Okay. Again, and don't just go, here's a Xanax. I know you don't want to do that, right? Don't just say, here's a pill to calm you down. Really sit down and talk with that patient. Because I don't know about you, wouldn't you be anxious? I've been a nurse 33 years, I'd be totally anxious if that was something you I had to do. Managing depression. So again, sitting down and talking with them, seeing if they're depressed, seeing if you talked about it, Caitlin, your patient that had just lost his wife and then stopped taking his meds, right? So really having that conversation, and you guys are the ones that are at the bedside continually. You're going to know those patients the best. You're going to be the one that's going to come to the kidney doctor and say, this guy's really depressed about this. So really pay attention to that. See what they look like. Maybe get them some help. Maybe a psychiatric consult if they're significantly depressed. So a couple things. If I'm going home and I'm a end-stage kidney, I better know how to take my blood pressure and I better weigh myself daily. Because I got a call if I'm greater than 2 pounds, right? Why don't I want magnesium containing antacids? Nope. Can't excrete it. Their magnesium levels are high in chronic renal failure, chronic kidney disease. Cannot excrete it. So now we're just complicating matters. Okay. Yearly, because they're high risk for, and you could add COVID there too. Now we have another microorganism in the mix. Definitely dietary consult, nutrition consult, hands down. They're the experts. They understand. They know what exactly this patient needs. I'm not going to be the one to say I know exactly what it should have. Home care dialysis access site, which I'll get into a little bit. I had a lady that had a bunch of cats at home, and they hadn't seen her for a while, and she was covered in feces, and the end of her hemodialysis catheter was covered in feces. And they brought her in, and she was septic, and she died within, I think, an hour and a half of getting to our unit. Never have I seen a catheter look that bad, but they do get infected quite easily. So pay attention to what that insertion site looks like. Okay, and I'll show you some pictures when we get to that PowerPoint. But really make sure that you are vigilantly looking at that site and making sure that it's not infected. And you don't just attach IVs to a dialysis catheter. You don't access it unless you know how to access a dialysis catheter. And then if you could do support groups as well. Oh my God, is he not the cutest thing? So our next step, we'll do a little bit, maybe 15, 20 minutes to start with dialysis so we don't get behind. But I'm going to talk about intermittent or IHD, intermittent hemodialysis. So if you see that abbreviated IHD, that means 3 times a week, 4 times a week. I'm going to talk about peritoneal. CRRT is continuous renal replacement therapy. And then renal transplant, I'm not going to talk about it all, but that is an option, correct? If I was an acute kidney injury, maybe a trauma, and then my son wants to donate a kidney to me, it is an option. But I think you talked about transplant. All right, so pull out your dialysis.
It also says goal.
I know. I'm sorry. I'm a failure. Yeah, yeah. Now, we are not going to get through this today. And then at about 11:30, we'll go over the case study. There we go. All right, so let's just recap here for a minute. Talk to me about chronic kidney disease and chronic renal failure. How do we know the difference? So it's progressive, but what's the difference between chronic kidney disease, Nick Gentile and Walmart, and chronic renal failure? Okay, but what does this mean then? Probably dialysis, right? So if I have chronic or end stage renal disease, I was going with the GFR. If I have that GFR that's less than 15 and it's end stage renal disease, when I get to stage 5, end stage renal disease, GFR less than 15, now I got to talk about some sort of renal replacement therapy. You got that? Depending on the GFR. Chronic kidney disease, I can be on all those medications. Can't I have maybe stage 4 and need to take iron and need to take the bone medication and things like that? We see it more with the end stage because there's nothing, right? No function with the kidneys. So it depends on where we're at. Okay, but when we're talking about renal replacement therapies, it could be due to an acute kidney injury, a very sudden cardiac arrest, and the patient goes into acute kidney injury, or it could be chronic. Make sense? So it could be either or. Hopefully with the acute kidney injury, we reverse it and they get off dialysis, which has happened. End stage, I can't, it's end stage, unless I get a new kidney, right, guys? Unless I get a transplant. Okay. So there's your objectives. And we'll talk about the different types of dialysis as we go along. And the vascular accesses that we are going to use, like your uncle, we'll talk about those types of things and how we can take care of a patient that's on dialysis. Who's gotten a patient back from dialysis? Anybody? What did you have to do? Why? Yeah, I like it. They tank. I like it. So yes, they can become hypotensive, right? We're pulling fluid off. So very tired. Yes, right. They sleep. 100%. They're sleepy. Don't expect them to go to physical therapy, right? They're tired. Now, some people, the longer they've been on it, they sort of adjust. But if this is a brand new patient on dialysis, man, they're going to sleep the rest of the day. Good. All right. Here's what I need you to understand. It does not fix the kidney function. Let me repeat that. Does not correct the dysfunction. So if it's an acute episode, we just have to wait it out and see if those kidneys sort of do their own thing, right? If it's chronic, all we're doing is maintaining their life because the kidneys are damaged. Make sense? So it does not fix the dysfunction. It's a bridge for the acute kidney injury patient for to allow those kidneys to sort of get better. And it's a way of life for somebody who's end stage kidney disease, right? Unless I get a new kidney, unless I get a transplant, which has happened. So we can use it in acute kidney injury, we can use it in end-stage kidney disease. You might see it as ESKD or ESRD, end-stage renal disease, the same thing. Okay. So we're going to talk about each of these. Intermittent hemodialysis is probably what I think when you were talking about tanking and coming back is what is common. And what we want to get that patient on is a Monday, Wednesday, Friday sequence, a Tuesday, Thursday, Saturday sequence. An intermittent is for several hours, maybe 2, 3, 4. Some patients are 4 times a week, depending on how bad they are. So that intermittent is, we have a special dialysis nurse that comes in, runs the machine. They come into the ICU and run the machine. I don't touch the intermittent because it's a very fast pump speed. Okay. Peritoneal, and that's a preference. So when I'm meeting with a nephrologist and we're deciding that I'm having kidney failure, I can choose whether I want to do hemodialysis or peritoneal. Now, there's some absolute contraindications to peritoneal, and we'll talk about that as we go along. But I have to sit and sort of process that information and say, well, which one would I want to do? Peritoneal, I could do at home. Guess what? I could do hemodialysis now at home too, because the patient just told me that. So it's really important for the patient to be educated on all types, and then they make that decision. Okay. So they make that decision. And the CRRT, all I want to put next to that is only in the ICU. That's the only place that we do CRRT. I'm going to get to, because all that means is continuous renal replacement. CVVHD is the alphabet soup of what CR, because there's several different things we do. So this, I like this one because the slide does a nice job of differentiating of when we would go in what direction. So if I acutely need dialysis right now, you are not going to do peritoneal dialysis. You guys see that I have to get a catheter put in. It's not for an acute. So if we look at peritoneal, slower than hemodialysis, and it's not for acute bringing down the potassium and those kind of things like that. Okay. Now, let's just break it all down. So hemodialysis I could do for acute poisoning, like I overdosed. Okay, I had a young girl who overdosed on Darvocet. We don't even do Darvocet anymore. But she ended up causing herself a renal failure. So she caused her liver and her kidneys to both fail. We put her on CVVHD. Her pressure wasn't able to tolerate. And that's why we would do inability to tolerate hemodialysis or peritoneal. So not everybody, because it's a one-on-one to the nurse to do the continuous. More money, more time. So not everybody goes to CRRT. If I am hemodynamically unstable, means I'm on vasopressors and I have a low blood pressure, I'm going to have CRRT. You guys get that? That's why you see it in the ICU. They're hemodynamically unstable. Intermittent, I got a good blood pressure, I'm stable, I'm on a general floor, I'm probably going to go to intermittent. You guys get that? The peritoneal, and again, I think a lot of it has to do with what, if I have significant COPD, would peritoneal be a good choice? I have excess fluid sitting on my belly and it's going to impede my breathing. Or if I've had many abdominal surgeries or infection, we're not going to choose peritoneal. I'm not even going to be an option. I'm going to have to go hemodialysis. Do you guys see that? So you really got to think about what's going on with the patient. Okay. Intermittent hemodialysis, we got to be hemodynamically stable because they're pulling fluid off pretty rapidly. So I got to have a decent blood pressure. Okay. Continuous renal replacement therapy. Think of, Joe's going to talk about multi-organ dysfunction and MODS. That's what that is. Sepsis. I know the renal guys love to use it in sepsis. Or acute kidney injury of the hemodynamically unstable patient. Because if I'm in acute kidney injury and I have a decent blood pressure, I'm going to regular dialysis. You guys see that? Way more cost, time, staff needed to do this. Peritoneal, if I have peritonitis or inflammation of the peritoneum, I may have to get off of peritoneal dialysis and go to hemo. Do you guys see that? Because that's an active infection. So again, these are just different reasons of why. All of them, oh, look at infection at the top there. You guys see that? Biggest complication. Okay. And with CVVHD or CRRT in the center there, it's a slow pump speed, so it's pulling the blood off slower. The potential for clotting is increased. And if you go on with CVVHD and they were like, oh my God, it clotted off again. Because it's moving slower. Where hemodialysis, the pump is going so fast, it's pulling the blood so fast, we don't have that problem now. CVHD, CRRT, slower. So the blood sort of sticks around and the potential for the clot off is increased. All right, so IHD or intermittent hemodialysis. And I am not going to ask you a patho question, which diffusion and ultrafiltration. I'm just giving you background information. Couple things. If you're putting a patient on intermittent hemodialysis, hemo meaning blood, I have to have an access, right? So I have to have a vascular access. Not a peritoneal catheter, I have to have a vascular. I'm going to talk about the different ones. Then I got to have this fancy machine that pulls the blood out, cleans it, puts it back in. Okay. And that's the dialyzer. So this little filter, that filter, that right there is the filter. If you guys see that, we call that the kidney. So this little guy, this filter acts like my kidney. So when the blood goes past that, cleans it, and then we pull it and we put clean blood back into the patient. We pull up all those wastes and put clean blood back into the patient. Okay. So I've got to have an access. We'll talk about the different ones, we didn't get to those yet. I got to have a machine that transports the blood from the patient, cleans it, brings it back, and I got to have a kidney or filter. Okay. So if it's an acute, like my young man that came in the cardiac arrest and we needed to dialyze him right away, we put in a temporary catheter. And I forgot to bring him up, but I'll bring him up on Monday. One, it's quite long. So do you see how long that is? And it's only in the venous system. Let me say that one more time. It is not in the arterial system. It's only in the venous system. So if somebody's cardiac arresting and we need to dialyze, we put it in femoral, dirty place, dirty. But I don't want to drop a lung, you know, and I'm worrying about getting a line in so that this is an easier access. So you may see a temporary one go in the femoral. You may. That means I can use it right away. So I got the dialysis nurse there. We're pulling this stuff off and we're taking care of business right then and there. So temporary, use immediately. Subclavian, IJ. I never like it in the IJ. It seems like it's so uncomfortable. And then femoral. Only in the venous system. I need to say that one more time because, not because it's a stress question, but because somebody drew blood from this and sent a blood gas off. It's in the vein. It's not in the artery. So please do not do that. So one of the things is it's a temporary line, high risk for infection. Didn't we just talk about that? You are not to access this unless you are trained to access dialysis catheters. I had to take a 16-hour class and then I had to do preceptor for 16 hours before I was allowed to run the dialysis machine. So if you are like, oh, I see a nice line that I could run IV fluid, you have to be specifically trained in accessing these lines. And we don't use these just because, oh, I'd like it because it's a good IV. Because the less we access, the better because they're the increased risk for infection. Now, at the end of it, I want you to see these 2 white clips. Those should always be clamped when we're not dialyzing because if they are open and the caps fall off, which has happened, I can exsanguinate. It's a big, and I'll bring it up next week. It's a big, thick catheter, but I can bleed out. Okay, so they should be clamped. The little white things should be clamped when not in use. And they actually tape them and double tape them. There's a certain process that they do to ensure that it does not become disconnected. So depending on what type of dialysis or what we're doing with it, at the end of the dialysis treatment, they will put heparin in the catheter, not in the patient. So every time that they go to access that catheter, they have to pull that heparin out. Otherwise, if you push in, you are giving them heparin. So they're just going to put heparin in the catheter, not in the patient. That makes sense to you guys? That's why you can't access it. You guys got to know what you're doing. There's a certain scrub that we have to do, and it's a process. So now remember I just said it's only in the vein, right? Only in the vein. It's a double lumen catheter. So if I took that catheter and cut it in half, there'd be two lumens. You with me? Together. So one of the lumens, you pull the yucky, dirty blood out. You with me on this? One of the lumens, you pull the yucky, dirty blood out, and we take it over to that filter. Then we clean it and we push it back. So here, if you look at this, so we want to see how it says pump to hemofilter. We're pulling the blood out and putting it back on the other side. So over here in the red, and this is why we call it an arterial port and a venous port. There's two ports, but it is not in the artery. Let me say that one more time. It is not in the artery. The ports are used to tell us which way the flow is coming. So the arterial port, this red port, we pull that dirty blood out. Okay, bring it over to the kidney, clean it, and we bring it back on the other lumen. They don't mix, to the other side of the body and do clean blood via the blue port or the venous. That makes sense? And we're all staring at me like I'm speaking Portuguese. Questions? So let me show you again. This is a one catheter, but two sides to it. If I cut it in half, and I'm going to bring them up next week. There's two lumens, just like your triple lumen has three, same concept. So I'm pulling out on the arterial side and taking it to the machine. That's how arterial blood goes. It's away from the heart, right? That's why we call it the arterial port. And then I'm bringing it back via the venous side. Okay. And I think I have a picture of the whole machine and everything, and I'll show you again. So let's say my acute kidney injury turns to chronic, and now I need a little bit more permanent catheter. I can't go home with this. This is temporary. You got it? Use immediately, maybe a week. Then we got to decide what the heck we're doing, right? So then I'm going to go to surgery. And a vascular surgeon is going to put in, I'm sure you've heard Casio, right? Okay, that's what this is. Casio catheter. It's a tunneled catheter, so it's more permanent. Beauty of this, I could use it right away. Long-term therapy, greater than a year. As long as it doesn't get infected or occluded, I can use it greater than a year. Big problem, infection and thrombosis. That's why you must protect your access. I cannot tell you enough. You must protect the patient's access. Don't let anybody touch it. Don't let anybody do anything with it. You must protect it. So this was my patient with the cat feces. These ports, the blue and the red, arterial and venous, covered in feces. So those two ports coming out of her body, covered in feces.
How does someone get covered in feces that severely? Wasn't sure if you had a backstory on that.
I didn't, because actually her son lived out of town. So I think she was on her own, like by herself, and probably was not well to begin with. And I don't know if she just didn't clean the litter box, you know what I mean? I don't know the whole backstory on that. Because I literally had her for an hour and a half when she died. I spent an hour and a half bathing her underneath the nails. Like I had her nice and clean. And she died. So. Yeah, it's tragic. So here's your Tessio. There's your little Tessio. One of the things I want you to look at, the one on the left, you guys, has two catheters. Is it in the artery? No, they're both in the vein. You guys get that? However, we use it as arterial line and a venous side, right? Because the way the blood's going to flow to the dialysis machine. Now they've made it to where it's one down here and it splits off like a triple lumen does. You guys see that on this side? So depending on what type of line the patient has or where they got it inserted. Vascular surgeon, you are not to access this. Okay. So, and as you can see, they have it dressed. Patients at home with the Tessio usually don't put a dressing on it because it's a tunnel catheter and has that cuff to kind of protect from things going inside. You with me on this? So it might be underneath your shirt and nobody would know. When they come to the hospital, because there's so many bugs, so many things, we cover it. Dialysis puts a dressing on and they change it. Okay. We don't mess with it unless you're trained in it. So protect the catheter, aseptic technique. They shut the door, they mask, they do a specific scrub before they access that part. Okay. Do not use for anything else. Now, have I asked to use it to run fluids because I have absolutely no vascular access, no IVs? Yes. In a rare instance, the nephrologist will say, okay to use for IV fluids. It's not assumed because the more you access it, the more chance of either clotting it off or causing an infection. So you have to have an order from the nephrologist to access that for IV fluids. Most often than not, we don't. We're going to put heparin in the line, not in the patient. Heparin in the line, not in the patient. So like,
So how is it different when they're able to like run meds through the actual?
so that's going to be in their tubing down here, post filter. Because if I do it before the filter, it's going to filter the med off, right? So I'm going to give it after the filter and back into the patient. And a lot of times it's unrinsed back at the end of the treatment because I don't want to dialyze the medications off. Be silly, right? I take them to dialysis and I give them a med, it'll dialyze off. Be silly. But they do it when they're rinsing all that blood back into the patient. Okay. Bleeding at the site or the connections, and let me tell you, they can really bleed. So I think this might be where your uncle comes into play. The best would be something of my own, correct? Instead of a foreign line sticking out. Now, me getting a test here probably means I don't have the vasculature to build something within me, okay? So the Tessio might be, I just don't have good vascular. This AV fistula is all me. They take an artery and they sew it to a vein. The AV fistula is all me. So that's why you need to know the difference between a fistula and a graft. Because a graft is a piece of plastic, which I'll show you a slide in a minute. But the fistula is all native, all mine. So the less chance of a reaction, right? I'm not putting a piece of plastic in. Way better than inserting a foreign line or something along those lines. So they sew the radial artery or brachial to the cephalic vein. Here's the problem. This is not used emergently. We need and may need 4 months. So back to your case, Nikki, maybe they were thinking, in the, although they were putting a line in, they weren't doing a fistula.
Yeah.
So if I'm thinking fistula, because I would really like that, because then I have a little bit more freedom. I don't have a line sticking out of me. It's underneath my skin. I need time for that to mature. Everybody got that? So this is not emergent. It needs time for it to mature. We have to do hand exercises. We need time for it to mature. It requires 2 big fat needles. And I don't know if you've ever seen them access these patients. They're like garden hose needles. They're big, big needles. Okay. One's going to pull out of the artery side. One's going to pull out of the venous side. And I'll show you a picture next. Here. So what they do is they sew those together. And this is a vascular surgeon again. This is a vascular surgeon again. He's going to sew those together. And do you see how this venous side gets large? That's what we're waiting for it to be able to handle that excess flow. Okay, so the artery is now, instead of going down to the hand, it's sort of coming over here and making that vein distend. Do you guys see that? So that's what you see underneath the skin. Okay, and that's what it looks like below. Underneath. That's when you put your hand over it and see if it's furred. Okay, so assess patency at least every shift. If you lose patency, you have to call that vascular surgeon because they can go down and get a thrombectomy. They can take that clot out. So first thing you're going to do is you're going to put your hand lightly over it and fill the throat. So like a cat purring, you're going to fill the throat. And then you're going to take your stethoscope and you're going to auscultate for a brew. I do both. So I go like this, something stethoscope in, and then I listen. Swoosh, swoosh. Anybody listen to one? Mhm. Instruct patient to avoid compression of fistula. How do we do that? Absolutely. Sign above the bed, right? So no BP. What else? Right. And people go, oh, look at that big vein. Okay, people. No, no, no. That's a fistula. Don't. Let me tap that. And I'm like, no, 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 no. So big sign there. How else do I avoid compression?
No tight clothes.
Yes. I mean, there was a big, and I'm aging myself, but people were wearing those really tight like bracelets up here. Who does that, first of all? That seems so uncomfortable. But nothing constricting. Now, who are my grocery shoppers that don't like to go in and out of the house 17 times and carry all the bags? And I just did this the other day. So I stood there and I said to my husband, put them all here, because I'm not coming back on snow. And I lined them all up. Am I the only one that does it? No. I hate it because I have a detached garage and I don't want to go out and pull it. And I said, this is your one chance for us, load me up. So it's very important that you don't have them have all of those things. That would be a compression. Your purse. Oh, on the left side sleeper. So we would not do my fistula on my left because I tuck this kind of arm up kind of crazy. I would be compressing it in my sleep. Do you guys see that? So really important that, you know, I'd say do my right, even though I'm right hand dominant. I love to sleep on my left. I don't know why, but I do. So really all of those simple things, avoiding compression. And then you just get your husband to bring all the groceries in and pretend like you can't go back out there. So, all right, hand exercises. So one of the things that they might do is give a little ball. Have you seen people do that with hand? And we really want to strengthen that fistula up. Okay, so you might see them do hand exercises.
So just because that vein like is bulging, it just means it has excess blood. It doesn't necessarily mean there's occlusion or.
Correct. Correct. Because the vein, they're distended. That's the beauty of vein. So as we're beating that arterial blood in there, it's making that vein get bigger and bigger and bigger. Yeah, no, you want it to be big because you want it not huge. One of the students, like I said, showed me her uncle's and it was out here. I've never seen anything like that. So, you know, it looks like a worm underneath the skin. Big complication with this. Now we just sewed the artery and the vein together, didn't we? So down here, if it's here, can I steal blood from my hand? Yes. So that's the complication that we worry about is, you know, it's diverting the blood over into the venous side of the fistula and it's saying, forget about the hand. You guys see that? So that's called Steele syndrome. And it steals blood from these arteries here. A couple things you can do. Well, the patient will complain of pain because I'm not getting blood to the hand. Okay, just like an arterial insufficiency you guys learned last semester, I'm not getting blood to the hand. And you, yes, if you have a fistula here, you absolutely can check pulses distal to the fistula. People go, I didn't want to touch it. No, you can do that. It's okay. So there'll be a diminished pulse. Hand will be pale. And if you look at this hand, and this is your fistula here, this top picture shows the fistula right there. Right there. And then here is due to chronic lack of blood flow and that gangrenous. We shouldn't get to that. Do you see that right there? Gangrenous, due to the lack of blood flow. So a couple things you could do. Hey, oh my gosh, my hand's really, drop their hand down. Because if I drop the hand down, blood flow will increase to that hand. Okay. So put it in a dependent position, whether they're laying in bed, hanging off the bed. Put it in a glove. So you can Michael Jackson it. You guys do that. You guys remember Michael Jackson? I mean, he's been dead a while. Okay. All right. So his one glove, put it in the glove. You could wrap it in a towel, keep it warm. Because with warm, it'll vasodilate and increase the blood flow to that hip. Okay. You don't want to get to this, you guys. This is just prolonged ischemia to the hand. You don't want to get to that. I've not taken care of anybody. I've had people with amputated fingers. I thought it was due to their diabetes. It could have been due to this. I don't know. So they can clot. So that's when you lose your bruit in your throat. So that thrombosis, pay close attention to that. They can complain of carpal tunnel syndrome. And like anything else, it can get infected as well. I'll be graph and then we'll finish. We'll do the case. Okay, AV graft. So the first one was AVF, fistula, all mine, nothing foreign. AV graft. Now I got to put a piece of something in. Because I don't have the vasculature to make my own fistula. You guys get that? So now I got to add a piece of foreign. So what do you think about that? Increased chance of thrombosis too. So what they do, see, and that's underneath the skin, guys, not outside the line. And a piece of plastic is sewn in it. That's why you ask the patient, is this a fistula or a graft? Ask them. Okay. More prone to thrombosis, infection, and stenosis. And the other thing is could I damage it by accessing it in the same spot over and over? Just like when you guys did IV meds and stuff in the IV and you kept hitting the same spot of that vial. Where it started leaking out. Same concept. So one of the things that dialysis people do is block their way up the graft. So they make sure that they don't continually stick the patient in the same spot. Okay. So this is just a picture of the AV fistula, all me. Best case scenario, all me. So in the artery and the vein together, and down below is a little foreign piece of vortex, whatever. The graft, now we have the foreign substance. And again, it's really just what's going on with the patient. And then I just put this in there because that's exactly how they feel. There's people coming at them with emails. All right, let's stop there. And let's case study it. I don't want to give you the answers. And then I will, as I leave here and go down to my office, I will upload the newer, my bad. I worked really hard on those. Couldn't tell though, could you? All right. There he is. Can you guys see that? All right, so Alfredo is a 38-year-old man in Texas, and he migrated from Guatemala a few years ago and lived in a small house. Primary language is Spanish, but acquired the ability to understand and speak some English. Like his mother, he has type 2 diabetes and is now insulin dependent. Has hypertension, decreased vision, and his feet are often cold and numb. Brings him to the hospital because he's having a hard time breathing. So, let's see if I remember how Jill did this. She just picked on you guys. If I recall correctly. What should the nurse's first action after placing Alfredo in the hospital bed? So, Sarah, what are you gonna do? That's exactly right, right? He's complaining of breathing, right? So he's complaining of breathing. So number 2, let's go down. Okay, so temp 97.2, heart rate 110, BP 122.75 with a mean of 91, respiratory 24 sat, 91 on room air, blood sugar 240, alert and oriented, lungs with bilateral fine, okay, moist cough, respiration, bowel sounds active, denies pain, states, I don't know Spanish.
That just means that you can't breathe.
He can't breathe. Okay, good. My sister took Spanish. I took French. He has 3+ pedal edema and a 1+ dorsalis pedis pulses bilaterally. So who wants to give me nurse thank prioritization? Julia does. So reflect on Alfredo's assessment. Top 3 assessments with the volume excess. What are you gonna look for?
I did the 3+ P.
Yeah.
1+ dorsal, exposed, and then the 5 practice was off, and then the 91%.
Oh, you added all kinds of more stuff. Yeah, that's exactly right. Crackles, the moist cough, and the pedal edema, right? Very good. All right. Let's move down. What should the nurse's priority action be? Ooh, let's see. Let me see. Who? Amber. Do you think? Think about your immediate, what can you do right away? Yes, because now it's funny because you all want to get right to that oxygen, but you're in the room and they're short of breath, put them up first, then run and get that oxygen. That's exactly right. Yep. Think about that when you're taking boards, you guys. Think about what you can fix while you're right there. If you had to go and make a phone call or if you had to go and get something versus a simple thing like putting the patient's head of the bed up, we could do that right then and there. Okay, so we've got a chest x-ray, O2 titrate to keep sat greater than 94. Oh, we're given some Lasix. Peripheral IV, blood count, comprehensive. So number 4. Place the prescriptions in order of priority, which the nurses should complete them. All right. 3, 4, 3. Yes, so 2, we're gonna place the IV. 4, we're getting that chest x-ray. 3, we're gonna give the Lasix. And 1, O2. So 2, 4, 3, 1. And I just talked to a graduate from December. She just took boards. Do you want me to tell you how many select all applies she got? And you know, she used her whiteboard to tally them. I said, what the hell's wrong with you? 32 out of 75 questions.
You only have to do one at a time.
Well, I'm just saying, I know you only have to do one at a time, but I'm just telling you the reason why we're giving them to you is to really focus on how we break it down. Okay. All right. But she did really well and she felt like ATI in this school. The nurse reassesses the oxygen saturation reading after 15 minutes. It's 94. What should we do next? Ready? Yep. That's right, harder than that. And you might think, well, it's right there. But he's having a hard time breathing, right? So let's increase that oxygen. Great. Okay, ooh, labs. Okay. Now, what you might see on NCLEX is something like this kind of tab, and it's going to give you a whole sequence of labs, and then you kind of got to differentiate what's like the most important or the most concerning. They may ask you those kind of questions. So they're going to give you the whole patient chart. And you may see, and yours will be test questions, but you may see tabs that you can click on and look at their flow sheet. You can go in between. Do you guys know that? Maybe I'm repeating something you already know. Okay. All right, so we looked at these labs. Chest x-rays completed. The radiologist calls the nurse to say the lungs have fluffy consolidation. How should the nurse interpret this report? Did I bypass that? I went too far. I did. It's not a lie. It's true. There we go. Okay, so chest x-ray completed has fluffy consolidation bilaterally. how should the nurse interpret this report? Jordan. Would you put? Yep, there's fluid accumulation in both lungs. So now let's just pause. What are you thinking we need to do right now? I'm thinking diuretics may be right, because they've got this excess fluid. And I'm thinking he has some probably chronic kidney, I haven't read this, so I'm just going on a whim. Some probably chronic kidney changes and maybe acute on chronic, right? Because he has diabetes and hypertension. All right,
How would you describe atelectasis?
atelectasis,
Yeah,
how would I describe it?
like, this is the ones that were fluid consolidated.
When I think of consolidation, I definitely think of fluid, like I see that a lot with pneumonias. Atelectasis just says collapse, it's collapsing of that one, back in the base, basal collapse, so they're not aerated. It's me needing to take bigger breaths. Okay. Yep. Okay, 7, the nurse is evaluating the client's response to the Lasix, which finding determined, now this is a key question to ask, is when you see what was effective. Now you're looking for that desired response, right? Those are going to be types of questions that you're going to be asked. Is how do you know the drug was effective? So, Nikki,
I did one, you're not put it 200 mils of the product.
why are we giving this Lasix? Yeah, but what was his problem?
Yeah.
So go with crackles bilaterally. Like, let's just pause here a minute.
That's in the lower basin, right? So.
If he's in pulmonary edema, Lasix will be effective.
But it's saying that the crackles are still in the basis. It doesn't say that the crackles are.
But he had fluffy consolidation all over, didn't
I think
Now
I
we're in a
don't really
basis?
understand fluffy consolidation, maybe.
he? So fluffy consolidation doesn't say basis, it says bilaterally. So if I do a chest X-ray and it's all, I'm in pulmonary edema. You with me? So when we crackles bilaterally in the lower base, that means my crackles, because in pulmonary edema, it's diffuse crackles. It's not like, oh, I'll pick the right base, I'll pick the left base. In pulmonary edema, it's diffuse. In a pneumonia, 100% you're going to see a crackles over here. So if I have decreased my crackles from being diffuse to just down in the bases, that's better. Does that make sense to you guys?
But why would urine output then?
Because I could still pee and still be in respiratory distress. Maybe I need to dump out, and that's only 50 an hour. Who cares? Who cares? Now, if you told me 2 liters, 200, that's only 50 milliliters an hour. Okay,
Because we're giving the diuretics to decrease, because I saw crackles and I was like, no. So we're giving the diuretics to decrease the lung.
100%,
That's what we.
100%,
Irrespective of urine.
100%. This is not a renal failure thing yet. Now, if we're looking at somebody who goes into renal failure and we're trying to get them to pick up their urine output, that's different. But his initial problem, this is where you got to differentiate. His initial problem is breathing, right?
And even though they're crackles in the bases.
It's better than diffuse because pulmonary edema is all over.
Well, it said in the beginning that there was crackles, what, like halfway up or something
Did
like
it?
that.
I can't even read this.
Yeah.
So there you go. You're looking at the decreased amount of crackles. Your heart failure patient, we're not giving the Lasix to make them pee. It's a really beautiful way to see that that drug's working. We're really evaluating those lungs.
See, I think I probably just overthought too, because it's like, okay, if it's in the lower base, it doesn't say it's not higher, it just says it is there.
Yeah, but from the previous, like she said, mid.
Right. But just
Better.
because it's in the basis doesn't mean it's not in it too. That, it's just me completely everything.
You were way overthought that because that nurse assessed and said there's crackles in the bilateral basis. She didn't say that it's mid too. She would put that if it was.
Right.
You overthought that way.
I mean,
Yeah.
hey. that's-
Yeah.
Like for nursing school. Overthink everything.
Yeah, you really, if you're talking about pulmonary edema, you guys, you want to go back to those lung sounds. Let me just make that really, really clear if you guys don't get that. Urine output's great. You are absolutely going to be monitoring that urine output because you gave a diuretic, but it's really to see if his respiratory status has gotten better.
Makes sense.
Yep. Okay, let's move down. Where are we at? Thank you. What hypothesis can the nurse make from the lab and the chest x-ray reports? So, Michael?
He has renal insufficiency covered.
Okay, and what reflects insufficiency? So let's go back up.
I was looking at the G learning creatinine.
Yep,
So he's having some issues with. Stiffness.
Do you guys see that? So that 2.9 is double what a normal, and we don't have a baseline from him at home, do we?
I don't think, not to our
I
knowledge.
don't remember that, because I actually started these case studies years ago and I forget. But so we don't have a gauge of to say, is this an acute or chronic kind of thing? We can make the assumption because of the diabetes and the hypertension, he's getting worse, right, guys?
His electrolytes are all jacked up.
Say it again.
His electrolytes are all jacked up, so they're not getting filtered out.
I heard something over there. Okay, so jacked up. Let's see what he means by jacked up. Okay, so see and I want to pause on this because this is beautiful for reviewing my stuff. So this magnesium is 2.6. Remember that they have high magnesium levels because they can't excrete it. Okay, they can't excrete it. Phosphorus is high because I can't excrete it. Sodium. Ooh, look at that. Remember I talked about sodium? Right. He's in fluid excess, so it's diluted out. It's diluted out. And then his blood sugar has been wacky. Okay, where do I skipped over K. Where's K? Magnesium phosphorus. Oh, right there. 5.5. What are you going to give him? Where are you going, Bernie? She's got her GPS. We're at 942 Belmont Avenue, 932. What are you giving me? So it's 5.5, and he's not. So Lasix might be one. What else are you giving me? Because it's only 5.5. It's not 7.5, 8.5. So the Lasix may help if he dumps out that, and he's going to spill potassium that way. And if we can't get it down, we can give that Lokelma. I probably wouldn't go with the insulin in the D50 just yet. He starts progressing. Yes. And look at his count. Why is his count low? I mean, it could be partially, but do you think it's diluted? He's in full fluid volume excess. The sodium's low. So if you diurese him, do you anticipate that hemoglobin going up? Yes. Do you guys see that? So you got to look at the whole picture. He's in fluid volume excess, is he not? We've determined that because of the pulmonary edema. So if I diurese him and he makes urine, I anticipate that hemoglobin going up. Now, will it be normal? I don't know that, but I anticipate it going up. If it goes down, then he's actively bleeding somewhere, right? All right. What are we on? 9? Okay. So 9. What should the nurse include in Alfredo's plan of care? Select all that apply. Ooh, who hated the select all that applies? Not all of you. Alex. It's going to be you. I just engaged in your eye contact. Oh my God. She said I looked away. Oh, I knew it. I could totally pay attention. Oh my God, I just said this.
1, 2,
So she wants my daily weights. Thank you kindly. Strict INOs. Oh, thank you kindly.
4.
Thank you kindly. Yes. Oh, you sticker. So 1, 2, 4, and 5. You knew that. Okay, Alfredo's admitted to the medical with dyspnea and renal insufficiency. A nephrologist is consulted and prescribes 24-hour urine collect. Oh, he's looking for that specific GFR. The nurse requests a translator to instruct about the process of collection. What should the nurse include in the teaching? Select all that apply. Ooh. Yeah, I like this one. Okay, Jake. What are you going to include in my teaching? So all the urine must go in the container over 24 hours. I like it. Okay, empty your bladder now before we urinate. That's our last thing. Good, but you skip one.
Two.
Nope. Great. So do you remember those orange containers? Have you seen them in the room? They gotta be in a dark container. Okay, good. And, yep, there will be signs in the bathroom. And I remember my first clinical was 110. I bring a student, I go over this whole thing. It's 24-hour urine. Don't dump the urine. It's gotta go in this thing. She goes in, flushes, and I'm like, so what happens when that occurs? What do I gotta do? And I looked at her and I said, give me what this time is from. So really important that you pay attention to that. Okay. Excellent. 10. 11. Alfredo's placed, oh my God, this goes right with what I just thought. Alfredo's placed on a fluid restriction of 1 liter in 24 hours. He's asking for something to drink at 22:45. Based on the intake record, what is your best response? Let me pull it up so you can see the record. So that's number 11. Would you say, Leah? You almost made your fluid restriction, but I'll bring you some ice chips. That sounds fair, right? That sounds fair. Okay.
I have four, because he still has 525.
So
455.
the quantity of fluid would exceed it by 40 minutes. If you give him a glass. So. I know it's nitpicky.
So when doing this, then you wouldn't like take out the outputs and stuff.
Say it again.
So it gives you intake and output. So like for the total wise, you wouldn't take out.
No, they're telling me a liter fluid restriction, that's all I'm allowed to drink. It's not even factoring in the output at all. I need to know the output. You're right. But he's telling me I'm allowed a liter a day. That's what I'm gonna do. I'm gonna drink it to the last ml. I'm gonna slurp that last ml. All right. 12. 2 days after admission, nurse is calling an interpreter. His family's frustrated. He's getting weaker. The nurse reviews the record to better understand what's happening to address the family's concern. So what are you thinking there? So let's take a look at the trends. So hemoglobin is fairly stable, getting a little bit worse. Could I be cheating on my fluid restriction? These are all hypotheses in my head. I could be. Hematocrit, roughly stable. Calcium, fairly stable. Magnesium, ooh, didn't we start with a high magnesium? So our magnesium has dropped. Phosphorus, fairly stable, so whatever I'm giving him is not working. Potassium, going up, isn't it? So that low calmo is not working. Sodium, going down. So, and I had this patient. It's so funny because she was Spanish too and didn't speak English. And I had this patient came in with a sodium level of 120 something. And I said, you gotta watch your fluid intake. Well, they said she'd go in the bathroom, put her face underneath the thing and drink that way because nobody would give her the water. And every day I'd come back, her sodium would be worse and worse and worse and worse. And I could not get through to her. I could not get through to her. She ended up on dialysis. But she was cheating. You know, we were giving her what she needed on her trays and the nurses were following, but she would go into the bathroom and drink the bathroom water. So you got to be very, very careful with that. All right, so potassium's going up. BUN, oh, what are you guys thinking here? Absolutely, right? And then look at your GFR. Ooh, almost 5, right? Stage 4, almost 5, right? Okay. So he's getting worse overall, right? Wouldn't you guys agree? Not getting better, getting worse. What?
I think you let your last kid.
Me? Why?
There's a question up above that.
Oh my God. 12. Well, he don't want you to, let's see. He don't want you guys to miss out. The nurse is mentoring a second semester nursing student who's, oh, this is fun. Who's studying fluid assessment findings. Help the student match the appropriate. So let's see. We'll start with the first half. Amber, Beatty,
So I have A,
for hepatomegaly, yep.
A,
Cerebral edema,
A,
B.
no, B.
Orthostatic hypotension is gonna be a fluid line deficit thing, right? That's where we do those ortho blood pressures and heart rates, yep.
I have B for tachycardia.
Could be both, could be both. So C, go ahead,
Then A, that's pretty good.
fluid deficit. Ready, pulse fluid, because if I'm in fluid excess, it's gonna be bounding in like a 4+, you know? All right,
And then B for third.
yep, correct. All right, so let's see. Olivia. Weight gain, yep. Yep. B. B. Remember, we're gonna be cold, clammy with a fluid volume deficit. A. A. Very good. You two can thank Michael for finding that question. Okay, let me go back to how exciting these labs are. Okay, so 13. All right, so reflect on Alfredo's trends in the data, which we sort of chatted about, didn't we? So tell me the top 3 priorities. Go ahead, Kenzie.
Worsening oxygen.
Yep.
Elevated potassium, and decreased kidney.
Yep, so worsening oxygenation, right? Rising potassium and worsening kidney function, yep. Okay, now let's go to 14. Knowing Alfredo's condition is worsening, what potential complications should the nurse be monitoring for? So knowing that it's getting worse. Oh, let me just cover these. Bless you. Heather.
Cardiac arrhythmias.
Yep, because of the high K, right, guys? Yep, go ahead. Yes, to the fluid access.
And sepsis.
Not necessarily. No indication that it's a concern right now, but I like where you're going with that. I've got to worry about that. Okay, because the white cell count is getting low.
No,
No,
it's
it's
elevated.
All right, calm it the hell down. Jesus, Mary and Joseph. Let me go back up. Was any of the neutrophils or basophils or any of that? Okay. Ooh, now, let's pause, because this is a great discussion. Can my white cell count go up and not be reflective of infection? Why? So if I'm on steroids, what else? Okay. What about physiologic stress? Is he on stress? Okay. I mean, it could. All right. Let's keep going. I know you guys want to get out of here. You're sick of me. All right, so. What'd you say over there, Michael? Oh, that's right. You have class after this. I forgot. Okay, to determine that Alfredo will be starting on hemo. Oh, this is beautiful. Temporary catheter. How long can I keep it in? About a week, right? In his right IJ. Remember I told you I hate the IJ? What should the nurse assess with this type of dialysis catheter? We just started touching upon this. Nicole, girl, do it. It is. Yes, because remember, this is a vascular access in the vein, and we won't have a biliary tract. Okay. And the circulation to the extremity would be more with the AV fistula or AV grant. Crap. Deb clinical just killed me yesterday. And then radial pulse, it shouldn't make a difference. Okay. All right. Moving down. The nurse learns that Alfredo, ooh, we didn't talk about this, but let's see if you get it. Several medications do. The key word in this question is hold. And that's really important because there's some medications that we never give before going to dialysis. Sarah. No, I think your phrase was tank them. Yeah, we're gonna tank them, great. Yep, the Lasix again, because they're pulling fluid off. And yeah, why the amoxicillin?
They're not gonna get it.
They're not gonna get it. You're gonna dialyze it off and it's not gonna treat whatever infection. So it's really important that you pay attention to what medications. And I always ask the dialysis because it changes. I'm like, what can I give? What can't I give? All right, 17. I think Taylor's gonna do this one. Come on, Taylor, do it. T.
So these are not very detailed, but top three, I put like maybe his alert oriented, his neuro status, his fluid status, like his BP and heart rate.
Yep, tachycardia and the blood pressure. Yep.
Yep.
What else?
What is it? His neuro status, because he's sleepy, but he is arousable.
So are we sleepy after dialysis treatment? It could be. What about his blood sugar?
Oh, I think, oh, yeah.
Yep.
Yep, drop in blood sugar. So then for the age of the insulin, fluids or albumin to help. For the eye, but
Now let's go back to the age. See, you guys go right to medical treatment. What's the quickest thing we could do to help this patient with a drop in blood pressure? Put the head of the bed down, not up. You're gonna drop this pressure more. So you're gonna lower the head of the bed to improve blood pressure and perfusion. You said his blood pressure was low, right? Yeah. Put the head of bed down. Do not put the head of the bed up. You're gonna make them orthostatic and drop the pressure more. That makes sense? You guys will confused. What's I?
I like obvious risk for falls
Yep.
or risk for shock because of blood pressure.
Okay, so we're gonna keep them in bed, right? We're not gonna get them out because we're definitely worried about them falling. And
So I would probably assess his respiratory status and assess his neuro status a little bit better.
what about blood flow? His blood pressure is low. So think of hypoperfusion and the hypoglycemia. People will die from hypoglycemia more so than hyperglycemia, right? That was a tough one. Okay, 2 more and we're out of here. I'm out of here, you're not. 18, what action should the nurse take in response to post-dialysis assessment? Ooh, this will help us. 18. Who wants to do 18? Go ahead. So 1, lower the head of the bed, yep. And 3, have him drink some juice. Yep, because he's hypoglycemic, right? Very good. Okay. And then 19, over a few days, he improves. Preparing him for discharge, what's important to include? Complete the discharge instruction on the following page. So let's see. What do you want to include in his teaching? What kind of diet? Let's start with that. Low potassium, low protein, low sodium, low phosphorus, high calcium, low carbohydrates. We can talk about that in great detail. Limit your fluids to 4.5 cups a day or 1,000 milliliters. Activity is tight. If becoming dizzy, stop, right? If he gets orthostatic. Dialysis catheter care, keep it dry, cover before showering. Do not bathe, so you don't want them immersing in it. Do not bathe or swim. Home health dialysis care team will change the dressing weekly. Follow-up dialysis every Monday, Wednesday, Friday. They should call and confirm that. Somebody didn't confirm that and they went home and just didn't get the dialysis treatment and went back in the hospital. Daily self-monitoring. So what am I going to do daily? What am I going to take? Weight or pressure? Good. Problems to report. What should I call him about? How much?
2 pounds overnight or 5 pounds a day.
Okay, good. Okay, good. What about my blood sugar? So all those symptoms like increased urination, all those things that go with high blood sugar, because a high blood sugar will then increase my risk for infection. Good. And then medication instructions. So you have regular insulin, NPH insulin, metoprolol, which you guys know. The renal vitamins, what's going to do to my stool? Darken it, good. Aluminum hydroxide. So what am I taking that for? I'm binding with the phosphorus. And then Pepsid, why am I taking that? To prevent? Okay, last question. Using the interpreter for discharge, oh, no, I did that one, didn't we? No. Nurse identifies he's concerned about complying with the renal and, a diabetic renal question, with preferences of his traditional Hispanic food. What action should the nurse take? Identify a Spanish-speaking dietitian in the community that can help Alfredo. Excellent. All right, guys, we are done. I think Deb's here to go over your, I'm going to stop recording.